invoke God's blessings through a Saraswati Vandana. So let us be calm for 2 minutes for the prayer.
कुन्देन्दु तुषारहार धवला या शुभ्रवस्त्रावृता या वीणावरदण्डमण्डितकरा या श्वेतपद्मासना या कुन्देन्दु तुषारहार धवला या शुभ्रवस्त्रावृता या वीणावरदण्डमण्डितकरा या श्वेतपद्मासना दण्डमण्डितकरा या ब्रह्माच्युतशङ्कर प्रभृतिभिर्देवैः सदा वन्दिता सा मां पातु सरस्वती सरस्वती भगवती
Now I call upon Dr. Prabhakar Dasilla, Chairperson of the E-Conference, Professor and Director of MGM New Bombay College of Nursing, for the welcome speech.
Good morning to all of you, the executive members of Society of Midwives, India, Maharashtra chapter, resource persons, senior members in the profession, faculty members, delegates, and all the students. I welcome you, all of you, to this e-conference. At the opening of this conference, first of all, I would like to express my profound gratitude to our management who have encouraged us to carry on with this e-conference in collaboration with Society of Midwives, India, Maharashtra chapter. It is my proud privilege to welcome all of you to this 2 days e-conference. First of all, I express my gratitude and heartiest welcome to the Professor Mangala Joshi ma'am, the President, Dr. Shri Priya Gopal Krishnan, Chapter Secretary, Maharashtra, Mrs. Rohini Nagare, General Secretary, SOMI India, and Mrs. Jasmine Jassi, Treasurer, SOMI Maharashtra Chapter, for sparing their valuable time in planning and coordinating for this conference. I welcome all of you, ma'am. I'm also delighted to acknowledge the presence of the executive members of SOMI and the resource persons from various renowned institutions and universities from Maharashtra and outside states. We are honored to have all of you in this platform. I think my mic was muted.
No, ma'am. Audible now.
Doctor,
Ma'am, it is muted now.
We are honored to have the resource persons on day one, Lieutenant Colonel retired Mrs. Manormani Venkat, Principal, Manmohini Academic Institute, West Bengal. Dr. Neelimar Rajan Bore, Principal, Bharati Vidyapeeth College of Nursing, Sangli. Dr. Shri Supriya Potal Ray, Assistant Professor, Bharati Vidyapeeth College of Nursing, Pune. Dr. Rita Lakhani, Principal, D.Y. Patil School of Nursing, Mumbai. Dr. Manisha Kadam, Professor, Sadhu Vaswani College of Nursing, Pune. Dr. Sujata Sawant, Certified Lactational Professional, D.Y. Patil Medical College and Hospital, Pune. In detail, your biodatas and your achievements will be read by the convener at the time of the presentations. So I welcome all of you from my wholeheartedly to this e-conference. On day two, Dr. Sudha Reddy, Dean, Faculty of Nursing, Principal and Professor, Institute of Nursing Sciences, KLE Academy of Higher Education, Belgavi. Professor Praveena Mahaldekar, Professor Bharati Vidyapeeth College of Nursing, Pune. Dr. Usha Ugande, Editor and Chief, IJNS and Consultant Midwife, MON President, Nursing Honor Society. Dr. Supriya Chinchpure, Principal, Kamal Narayan Bajaj College of Nursing, Aurangabad. Dr. Nancy Fernandez, Principal, Leelabai Thackeray College of Nursing, Mumbai. And Mrs. Prachi Dharap, Principal, Saw Meenatai Thackeray Institute of Nursing Education, TMC. So I welcome all of you again. And I also welcome all the participants from different parts of the state of Maharashtra who have registered for the conference. More than 300 participants have registered for the conference. I'm sure the 2 days conference will have deliberations by distinguished speakers in the sessions, panel discussions, and the most awaited reflections by the practicing midwives, which will definitely help the participants, students, and the faculty members to recognize the current challenges in independent midwifery practices, identify strategies to overcome these practices, to improve these practices, and to get enlightened with new reforms in midwifery practices. Once again, I welcome all the speakers for accepting our invitation and for boosting our enthusiasm to make this e-conference a great success. Thank you very much.
Thank you, ma'am, for that warm welcome for all our participants as well as all the delegates. Now I call upon Professor Mangala Joshi, ma'am, that the President's Somi Maharashtra chapter to give the keynote address. Joshi, ma'am.
Hi, everybody.
Yes.
Good morning, ma'am.
Good morning.
Good morning, one and all present for the conference. It's very few days back. We have said goodbye to 2020 and we have entered in 2021. And that is how this is the first week of year. I wish you all very happy, healthy, and prosperous new year. I feel privileged to deliver keynote address in fourth state level conference of SOMI organized by MGM College of Nursing, New Bombay, Navi Mumbai. This college has progressed very fast within 13 years span from UG to doctoral degree program in nursing. NAC accredited with A grade. It's known for offering quality nursing education with highest ethical standard. I congratulate team of MGM College of Nursing, Navi Mumbai, for its great and amazing progress. Same time, I congratulate management for supporting progress of nursing college. Same time, I appreciate their association with SOMI and hosting this conference under the banner of SOMI. The theme of the conference is Rebirth of Midwifery in India, Challenges Faced by Midwives. Very rightly chosen theme while getting involved with SOMI. I take this opportunity to present information and clear picture of SOMI, how SOMI is striving very hard towards progress of midwives and midwifery in India. Greatest privilege of human life is to become midwife to the awakening of the soul in another person. Philosopher like Plato, Athenian has said, and being a nurses, we also should be thinking seriously regarding progress of our midwifery practitioner course as well as midwifery cadre in India. Society of Midwives, India, established in the year 2000, is 20-year-old registered association. It has its mission to strengthen midwifery as profession and enable midwives to achieve safe motherhood within socio-cultural, equitable, and ethical context. Objectives: work for high standard of midwifery education and services in India, promote research and use of evidence in teaching and practice, influence policy decision for safe childbirth, strive for independent status for midwives and midwifery profession. Activities of SOMI: advocacy program regarding nurse practitioner midwifery course with Government of India, Indian Nursing Council, and state government. Participate in international conferences, organization of national, regional, and state conferences, seminar, workshop. Joint partnership program with UNICEF for improving quality of facility level, maternal and newborn healthcare in West Bengal. A joint project of Society of Midwives India with Wari advocacy on creating and enabling environment for midwifery in India, in UP and Bihar. Symposiums for improving maternal and newborn health supported by Himalayan Drug Company. Skill development on NRP with IAP. SOMI made continuous advocacy. That's a highlight. That's a highlight. Organize workshop, seminars, skill training in association with Organization for Professional Midwives. Research work. Guide to SOMI chapters activities, advocacy, awareness generation. Celebration of International Day of Midwives, Nurses Day, Breastfeeding Week, Women's Day, etc. Significant achievement of midwives in the year 2020. Colloquium of Midwife Leaders, Asia Pacific region. Photojournals also came out during 2020. News bulletin, digitalization, advocacy, state consultation meeting. SOMI made continuous advocacy since its birth to strengthen independent midwife and midwifery profession. Initiatives. The campaign for safe motherhood with Midwives Lamb for Mother traveled 27 cities of India, carried by 18 SOMI chapters. SOMI promotes for normal birth. SOMI promotes for normal birth. Our vision is to have every healthy mother and baby going through normal birth in safe, skilled, and sensitive manner and make birth both memorable and pleasurable. Midwives aim to build an unbroken chain of care from home to facility and back to home. This campaign reiterates the commitment of nurses, midwives, health workers, doctors, and program managers at all levels to healthy and normal birthing for all. Normal Birth Campaign launched on 10th December 2018 at Delhi with the involvement of Government of India, WHO, and ICM. SOMI organizes conferences from 2002 till 2019. We had 14 conferences. If I go through all this, it will take more time. I will just highlight the starting and the end. How relevant themes are chosen by SOMI for conferences. First conference theme was Indian Midwives Move Towards Safe Motherhood. The conference, which was hosted at Raipur, Chhattisgarh 2019, which was 14th National Conference, Indian Midwives Voice for Normal Birth as Women's Right. 14th National Conference of SOMI from 26 to 28 September at Raipur in Chhattisgarh was grand success. For the first time in SOMI's history, representative of all important stakeholders such as Government of India, WHO, Indian Nursing Council, JAPIGO, and CNI were present and vouched support for reintroducing midwifery as a profession in India. More than 450 participants were present in the conference. There were many different activities. To look at few, there was exhibition organization, and the exhibition was inaugurated by President of Indian Nursing Council, Mr. T. Dilip Kumar. Whereas all these nursing leaders, in another picture you are seeing that squatting in solidarity, which is one of the comfortable thing for our mothers. SOMI and Answers. These are two different institutes, but they are brainchild of Madam Prakashamma. And both these NGOs representatives took part and presented in front of COVID-19 academic platform to celebrate nurses and midwives in this International Year of the Nurses and the Midwife. 2020 COVID-19 academic, WHO, UNICEF, HCLF Sphere, India webinar on midwifery held on 12th May 2020. Answers perspective, if we look at Answers area of interest other than COVID-19, they are very much interested in advocacy for clinical specialization and cadre of midwife, advocacy for midwifery course and midwifery cadre, TRAS, that is training and technical support, research, advocacy, capacity building. Other than that, morbid fear about COVID-19 used to be there, and to break that fear, to bridge the gap between knowledge, Answer was helping people. High level of stress and inadequate counseling was noticed by, and accordingly actions were taken. Poor arrangement, accommodation and food during quarantine period was brought to the notice of organizers or the institute people, or maybe wherever it is required, even up to the government level. Huge death of COVID-19 patients causing depression to the caregiver, that also was taken care by SOMI through counseling. Social and family impacts also were taken care of. If we look at SOMI regional conference held on 14-15 March 2020. West Bengal, more than 650 participants were present for the said conference. That shows how much SOMI is popular in the West Bengal and how they are getting various types of international facilities because of their interest. SOMI activities during COVID-19 pandemic. Midwifery expert group and identified problems and solved those problems. Urgent basis and guide midwives to render quality care. Mothers are supported by arranging transport and admitting them in hospital during super cyclonic storm, and by communicating with nursing superintendent and DPHNO. SOMI developed its position statement and it was informed to all the chapter secretaries and their members. Advocated with Government of India, state government for the adequate supply of PPE and at COVID centers. Conducted meetings with nursing superintendents for setting up labor room for COVID mother and newborn care. Discussed with nursing superintendents and for mothers baby care during the intranatal and postnatal period. Guidance provided to NPM and staff working in the labor room. That only was not the function or the activity performed. Other than that, in pictures, you are noticing that Meera Paswan from Lucknow distributed grocery to the community, which was a deprived community. The Mansi Jana Kolkata distributed masks to community as one of the preventive measure for infection control of pandemic. Meeting conducted with DPHN, BPHN, PHN, ANM, ASHA to render regular services at clinic, home and community. Organize clinic online meetings with SOMI chapter secretaries to know the problems faced by midwives to render services to mothers affected with COVID-19. Distributed masks and hand sanitizer by midwives at some centers. Distributed food to the community people by our midwives wherever it was possible and necessary. Conducted awareness program on the use of PPE, hand hygiene, cough hygiene. Distributed leaflet in the community regarding the prevention of COVID-19. Encourage ANMs to continue services for maternal and newborn, address their problem, trying to identify mothers in their extreme needs. Kolkata chapter provided training on infection prevention control, donning and duffing, and stress management at College of Medicine and JNM Hospital, Kalyani, Nadia, West Bengal. Whereas senior SOME members worked as telemedicine consultant to the family members regarding treatment of management of COVID at hospital and home. You are seeing in another picture where we can notice that there was flood in Assam. Still, ANM in Assam continued to provide uninterrupted services to community including immunization and other services. And that could happen, it was because SOMI was supporting and guiding. Of course, I don't say that government was not involved. Along with government, SOMI was going hand in hand. Karnataka Senior SOMI members provided services in hospitals. Photo journey of SOMI has come this way. This is the front page. SOMI has its various chapters and units. SOMI members, if we look at figure, it is 11,869 members spread across 21 chapters, along with 11 units of India, including Andaman. Andaman, there is unit of SOMI. You can imagine how hard SOMI is spreading units and chapters. SOMI activities at Maharashtra, if we see, few pictures and later on list of activities and again pictures you will have to witness. State conference, symposium, role of ANM in public health, Sadhu Vaswani College of Nursing, national discussion, challenges faced by midwifery faculty during pandemic, midwifery skill workshop at BBCon Pune, International Women's Day at Bhor Taluka, Safe Motherhood Day at Eroda Pune, Midwives Day at Siagat College of Nursing, a study on opinion of midwives regarding NMP in India, workshop on ICM competencies for senior midwives, taught on neonatal resuscitation by IAP for SOMI members, breastfeeding week at various institutions. These are the glimpses of all those activities just I mentioned. Next. Certain topics were covered under skill stations, and those topics were antenatal examination, antenatal education, identifying high-risk pregnancy, intrapartum monitoring, especially partograph, mechanism of normal labor, neonatal assessment, neonatal resuscitation, postnatal assessment, strengthening midwives in Maharashtra. All these activities were carried out by various colleges and units of Pune city. Next. Cases of midwifery skill stations, what I just mentioned, they are the same. Midwifery skill workshop at BBCon, where souvenir was printed and distributed at concessional rate during workshop. International Women's Day celebration took place at Bhor Taluka, means we reached from urban to rural area. Next. Taught neonatal resuscitation by IAP for SOMI members. Breastfeeding week celebration at various places. One of the places, Savangi Meghe, that is Vidarbha, BBCon, Sonone Hospital, Pune. Receiving the SOMI lamp in Sonone Municipal Maternity Home, Pune, where different corner and different organization leaders were present, mainly Advocate Puzekar, member of Rotary Club, Dr. Anand Shinde, President of Pune, Foxy, Mrs. Mananmani Venkat, Madam, Dr. Tapti Bhattacharya, Principal of Bharati Vidyapit that time, Chapter Secretary Shiva, Josna Deshpande, and many other members were there. Safe Motherhood Day at Bharati Hospital, Pune. Breastfeeding week celebration. Inaugural function of Somi Midwives Day Maharashtra chapter, Sinhagar College of Nursing, Pune. That time I was principal over there. Next. Future plans of Somi. Strategies for enhancing visibility. You all please note this because it is for us. We will have to prepare our mind to participate at national
Joshi ma'am, Joshi ma'am.
and international conference. Yes.
Hello ma'am.
One
Ma'am,
or two slides.
yeah, because it is already, we are short of time in this.
Only 2 minutes.
Yes,
Only 2
ma'am.
minutes.
Yes, ma'am.
Strategy for enhancing visibility midwives at 32nd Triennial Congress at Bali, which will be motivational, better for publicity, to create awareness, promote presentation of clinical research and case study. Before I end and talk about this displayed slide, I express my gratitude to Madam Prakashamma, to Madam Manonmani Venkat, Vandana Das, and Madam Mitali Adhikari. I just cannot forget Madam Rohini Nagre, who is Vice President at national level of SOMI. All of them, they have helped us to prepare this presentation as well as carry out various activities in Maharashtra chapter. I would like to create awareness regarding membership, and that is this slide. For ANM, if we want to enroll, fee is 500 rupees, BSc Nursing and above 1000 rupees, associate member 1000, international member 5000, institutional membership 50,000. If we want to go for patent, it is 1 lakh. Thank you. Thank you very much for your patience listening.
Preeti, you are muted. Preeti, you are muted.
Yes, ma'am. Thank you,
Yes.
Mangal Joshi ma'am, for that elaborate session regarding the SOMI, its activities, as well as the SOMI Maharashtra chapter's activities. A few things for the participant, that is kindly mute yourself throughout the sessions. And if you have any queries or questions, put your queries or questions in the Q&A section or a chat box. So at the end of the sessions, either you can ask the questions to the panelist, or we can raise a question which is there in the chat box as well as the QA box. And at the end of the sessions, that is by 12:30, we'll give you the feedback link. So kindly those who are there in the participated today, fill the feedback link so that it is required for your attendance purpose. And for tomorrow's session, we'll mail you the links as well as we'll WhatsApp the links. That is for the tomorrow's session. So today's sessions we are now beginning with. So our first panelist for the today's session is eminent personality, that is okay, she is an eminent personality, that is Madam Manonmani Venkat. She total 44 years of experience Madam is having in nursing. She completed her BSc from the Armed Force as well as MSc from the SNDT. Instrumental in establishing Sadhu Vaswani College of Nursing in Pune. The founder member of Society of Midwives India, and has been actively involved in various activities since its inception. Presented various national papers on the national and international level and attended various conferences and workshops. Presented SOMI at the ICN Congress held by Glasgow, Durban, and Prague. And at presently, she's working as a principal in Manmohini Academy of Institution, West Bengal. So we'll welcome you, ma'am, for the present session, and it is over to you.
Good morning to all of you. First of all, I would like to express my gratitude to the organizers. Am I audible? You can keep anyway, just keep only the first slide
madam.
on. Please don't put the other slides. Am I audible?
Yes, ma'am. Yes, ma'am.
Okay. I would like to thank the organizers, that is the state chapter, the Maharashtra chapter, and the organizing institute, that is the NGM College of Nursing, the principal and the organizing secretary and all the members. I bring greetings from the Society of Midwives India headquarters, that is from the president, Mrs. Mithali Adhikari, and the general secretary, she's of course there, Mrs. Rohini Nagare, and from the advisors, that is myself, Ms. Bandana Das, Mrs. Bandana Bhattacharya, and all the other members of the headquarters, that is Santhya, Rani, and other members are there who support us, Sadiq, and the Answers team, who have been constantly supporting us throughout our journey of the Society of Midwives India. Now, I congratulate, and I know you all are looking forward to a fruitful session of 2 days for this state chapter conference. I know which we have had in person many a times, and we really enjoyed the get together, the various presentations, and especially the skill workshops and the experiences shared by many midwives in the past. Now, today the topic is, your title of course is the rebirth of midwifery in India. So what happened to there was a birth, and then what happened thereafter? So something went wrong somewhere. So now we are trying to bring the midwifery back. And what are the challenges faced by midwives is your theme. And today I'm here to talk about, as prescribed, is the evolution of midwifery in India, the traditional and the future of midwifery in India. More than evolution, it may be the development of midwifery in India, which, the next slide can I have? And just keep it there. The next slide. The midwifery, I heard what happened, because maybe I was there because I was born somewhere around in the 50s, but I am not witnessed. So what I heard, what I experienced, and what is it now? And what do I envisage midwifery in the country in the future? Now, what I heard, it's all from one of the qualitative research in which I was involved because of some training on qualitative research which happened, which was organized by Answers at Pedapur. So my topic was the same, and I happened to interview quite a number of experts in this field, and the first one was Dr. Prakashama. So in that in-depth interview, I came to know a lot of history about how midwifery developed in India. In the earlier years, you know, the women were given a lower status. They were not given adequate care. There were a lot of women dying during childbirth and otherwise because of sickness. And when the queen heard about it, these women were prepared to die rather than receive treatment in the general hospitals along with women. I mean, with men. They didn't want to be treated along with the male patients. When Queen Victoria was informed about the plight of these women, she asked Lady Harriet Dufferin, the wife of the Viceroy of India, at that time to help find a solution. Lady Dufferin decided to establish hospitals exclusively for women and children. These Dufferin hospitals were located in Karachi, Quetta, Shikarpur, Hyderabad, in Pakistan at that time. I mean, now also it is there. Delhi, Nagpur, and Kolkata, as well as in Burma, that is in Rangoon. She appealed to the local philanthropists to donate Dufferin Fund, that is in England. She collected fund in order to build these hospitals. Today also, we see these women hospitals in cities like Kolkata, Chennai, Delhi, and other major cities, which was established with this fund. And from then onwards, the midwifery training happened. That is, there were midwives called as rural midwives. So the midwifery training had occurred at that time. Thereafter, slowly, after independence, the Indian Nursing Council was set up. you know, the military nursing started. Then the first nursing school was supposed to have started in Madras with a 6-month diploma midwives program with 4 students. Between 1890 to 1900, there were many schools opened in various parts of the country. So we had training of the ANMs, then the GNMs, then we had the first, after the INC was established, the collegiate program combining both the nursing and midwifery, the GNM and the BSc nursing started. So the BSc nursing, we know that it has got 6 months of training, and the GNM has a little more than 6 months, although the period, the duration is 6 months, but the hours are more than the BSc nursing program. Now, in the earlier days, we have heard, we have seen, not heard, all my contemporaries have witnessed the GNM program. After the 3 years of training, the students underwent 6 months of midwifery training in various midwifery schools. It was only purely midwifery training. Whereas in the BSc, it was in the final year, whether it was a 3 exam 4 years course or it was a 4 exams course, it was in the final year. Whenever they had midwifery, there was no combination of the other subjects. It was only midwifery which was educated. And these candidates, after passing out, they were posted in the midwifery area. They were very confident to conduct deliveries. And there were midwifery positions in certain hospitals, that especially in the government. And after that, we had the postgraduates, the post-graduation MSc nursing, we had, and thereafter, of course, the PhD and a lot of researchers and all that. At the moment, we have had the NPM course. Now, there comes, why this NPM course? The earlier days, the midwives were trained, they were competent enough, they were skilled enough to conduct deliveries and manage the antenatal area, the intranatal area, the postnatal area, and the ANMs were trained mostly as midwives. They were working as midwives. But what happened was that there was, because with all these 5-year plans, there was extra work given to the, more emphasis was given to family planning and immunization, and the ANMs were forced to do that work more than attending to mothers. So because of that, it got deviated. The midwife's role got diluted. So today we see the ANM training. There are many ANMs who are trained who have not even conducted one delivery. Now, in the meantime, side by side, the medical profession also was progressing. There were a lot of specialities. Earlier, we had only few gynecologists, maybe 2 trainees will be there. Today, there are a lot of private colleges, lot of post-graduation training, lot of obstetricians, everybody wanting to conduct delivery. The rate of cesarean section has gone up. The midwives are not allowed to conduct deliveries. In the private, definitely yes, and even in the government hospital, many hospitals, they do not get a chance to conduct deliveries. In the bargain, the midwives have lost their skills. They are not confident enough. They fumble to conduct deliveries. So that many of my colleagues will agree with that. So that is why this question of challenges faced has come. Now, the Society of Midwives has been working over a period of 2 decades, trying to advocate for the care of mothers and child, as well as promote midwifery as a profession, especially as an independent profession, independent practice. We do have 1 or 2 here and there midwives practicing independently. We hear of Dr. Vijay Krishna in Hyderabad. We hear about Priyanka in Cochin, and there are other few, Geeta Saxena in Delhi, and others who are struggling to do their practices. Yes, of course, Vijaya and Priyanka are doing well, but then that is not legally accepted. They have to struggle through. And now the new draft of the nursing and midwifery bill is on, and I had responded to that with the draft was at least we have to feel happy that the midwifery is included, but although specification of their job responsibilities or no midwifery act or a nursing act, practice act. I mean, the practice act is there. We cannot see that. So we all have responded to that. So that is what is the development history. That is, there were initially the rural midwives, there were midwives practicing midwives, but in India, to start with, it is not the training. We had the indigenous dyes, whom all of us, means my time people, contemporaries have seen. And I would like to narrate that my mother always said that I was born, I was, assisted by a midwife during the birth when she gave birth to me. Whereas all my sisters and brothers, I have 6 of them. So they all, I have witnessed them being delivered by a dai, the village dai, who used to come, conduct the delivery and come for a period of 40 days to take care of, that is to give bath to the mother and the child. And then we had special food for the mother prepared, especially they had mustard more, because I suppose mustard is a uterine contractor. So maybe that was why it was included. In other parts of the country, we see a lot of rich food being given, nuts and ghee, etc. So dyes were always prevalent there. And when we used to do even the postgraduate training, we have been involved in the training of dyes. And over a period of time, now it is not encouraged. Every delivery should be institutional deliveries. But unfortunately, although institutional deliveries are happening, everything we have maximum 60 to 70% of cesarean section happening in the country, which we all are demanding now, that we would like to have, independent midwifery practice. Now to talk about the NPM, which is the latest trend in midwifery, the NPM education has come. There has been a lot of webinars conducted. I don't think this is the right place to be discussing about that. So any BSc and GNM can undergo the training of the 18 months, because the previous training, whether it is BSc, GNM, or MSc, we do not meet the standards of the International Confederation of Midwives, which is 18 months. And there are certain basic skills required to be called as a midwife. So now, at the moment in the country, the NPM training has been advocated. There are a lot of NPM teachers beyond educated. The NPM trainees have been identified. And because of the COVID-19, the training is a bit delayed. There are a lot of recommendations have been given where these NPMs will be, that is the nurse midwifery practitioners, where they will be placed, what will be their career pathway. So SOMI is involved in advocating the state governments in their place, in their training placements and about their salary, etc. So we have been working with various state governments, states like Bihar, UP, and other states, and I think soon it will happen in the Maharashtra as well. Can I have this other slide so that I can just complete that? Can I have the next slide? I would like to just summarize and go ahead.
काय ते
Next
हा
slide.
हा बसवून टाका हा साधारण चाल आता काय तिकडे कोण जात नाही एवढं.
Can I have the next slide? Next one.
म्हणजे सगळं हे एक सेट तरी एकत्र धुतला जाईल ना.
Keep clicking. Please click.
Kindly mute, ma'am. Kindly mute anybody, those who are unmuted. Kindly mute.
So as I said,
Rohini madam, please mute yourself.
As DICE, the first training school for DICE by Janana Missionary Society in 1877. 1899, training of nurses with the Janana Bible and Medical Mission. 1918, with the lay reading health school was established to train ANMs. 1926, Madras Registration of Nurses and Midwife Act was passed. 1936, Dufferin Fund was sanctioned to build hospitals. The next slide, please. The independent India. 1946, 4th committee laid the stress for qualified midwives, health visitors and DICE. 1955, Shetty committee recommended the training of ANMs. 1959, Bishop, a technical consultant, supported the training of ANM and GNM training, 3 years plus 1 year midwifery. 1947, INC took the first step to combine the nursing and midwife course into a single course. 1960, 2-year credit for ANMs. It was earlier 18 months. 1966, ANM rule changed from midwives to family planning and immunization, where the dilution of midwifery happened. 1975, the 2-year course reduced to 18 months as they were designated as female health workers. Now the designation became female health workers. And at present, next slide. So we have the ANM training ongoing, the GNM training ongoing, the BSc training ongoing, and the MSc training ongoing, where everywhere all of them learn midwifery as a part of the training. But when it comes to placement and practice, there are hardly any seekers to be at midwifery position. Seekers are not there, as well as there is no post created. But the new NPM training, I would like to mention there, it was the Fernandez Hospital in Hyderabad. They had started training midwives on their own, with their own curriculum for a 2-year course. And Dr. Fernandez, Evita Fernandez also took up this case. And the NPM training of the first, one of the courses was conducted in her hospital, and they are placed. And that is the new 18 months NPM course. But to go history back, the NPM course of 11 months course was started in 2000 in the state of West Bengal and Gujarat. Now these people were trained for 11-month training
Conference.
which was the IFC. But after training, there were a lot of problems encountered by both the state governments, the West Bengal as well as the Gujarat, for the placement of this trained NPMs. So there was no motivation from the midwives, because there was no career path for them, designed for them. But at present, the course have been created and they have been placed in various places in West Bengal as well as in Gujarat. And the new NPM training, new career pathway, it is advocated that they will be posted in the midwifery-led care units. Now the question is it midwifery-led care units or midwife-led care units? So it's midwifery means we are practicing midwifery. That is, anybody can prepare midwives. It can be called as a midwife who is practicing midwifery. So we would like to have midwife-led care units. These NPMs will be posted there. The center will be totally managed. That is, the normal cases, normal pregnancy, normal delivery will happen in this midwifery-led care unit. And these NPMs have to be confident, skilled, and sensitive. Now that is about the development of midwifery in India. Of course, I missed stating developments. There were trained birth in between. We had people called as trained birth attendants. A lot of training programs was done for them. There was a lot of researchers to see whether their training was adequate, whether they were skilled. And then we had the skilled birth. So these were all ANMs and anybody who were skillful in our GNM, BSc, or a medical officer trained to practice. We call skilled birth attendants. Can I have the next slide, please? What is the future of midwifery? So we look forward to midwives with a lot of NPMs who will be passing out. We look forward to a midwifery-led care unit where all over the country, where midwife will be sought after by the pregnant women once they become pregnant, and in the various other countries where we have witnessed a lot of midwives of our country. Care. When we visited Sweden and Finland, we had seen whenever the mothers become pregnant, they call the midwife. So midwife attends to her. I had an experience which I have shared many times in Maharashtra whenever I spoken. One of the Indian ladies that came to Pune, she had called me to say, I would like to have a midwife. I am pregnant for the second time, because the first time when she was in England, she had a midwife attending to her throughout her pregnancy, who took care of her, who gave her counseling about her pregnancy, the diet, etc., and who conducted her delivery. Whereas here in India, she couldn't find one. We did support her, we did guide her what she could do, and said that you are available to you whenever you need, but we don't have such a system in India. But I wish that we have such a system, in India, and I am sure Maharashtra should be the first one to take the lead. I'm sure Pravina is there. We did try establish a midwifery care center in Pune with all the so many members present there. There was a lot of study was done, research was done, but unfortunately, not started. Wanted to be on the telephone for the 24 hours, one of us on duty, advocate midwives, mothers who are in need. So that's what I envisage. Midwifery in India in the future, where midwives will be midwives will be skilled, and mothers will look forward to the midwives for their antenatal, intranatal, and postnatal care, and throughout their lifespan, from the time they're born till there. Thank you for that. And I would just like to add, it's my pleasure to be in Maharashtra. It feels like coming back home. And a little bit about the Stomi Maharashtra. So I'm happy to say that I was the first one, first chapter. Thereafter, Sujata here as a speaker, then secretary, then we have the evolution of Maharashtra chapter. Then it was Pravina, and thereafter
भाकरी खाली
Pravina. Thereafter, it is now Dr. Sri Priya, and I congratulate all the plan for the future. Thank you.
Preeti, kindly mute everyone. Preeti, please mute everyone. Somebody is interested in watching the TV, please let them watch TV.
Yes, ma'am. Yes, ma'am.
Preeti, there is lot of disturbance coming in.
Hello, ma'am. Muted everyone.
Please take care. Yeah, thank you.
Hello.
Can I share the next slide, ma'am?
Preeti madam has finished.
Madam has finished.
Hello.
Hello.
Hello, ma'am. Yes, ma'am.
Yes, I think madam has finished probably. So you can just continue.
Okay. Thank you, ma'am, for sharing your vast experience as well as the future as well as the past of midwifery in India. Now we'll move on to our next speaker. The next eminent personality, that is Madam Nilima. 1 minute, ma'am. Madam Nilima Bore. Madam has got total 32 years of experience in various fields of nursing and completed her BSc as well as MSc nursing from that is from the SNDT University Mumbai as well as the PhD from Bharatiya Vidyapeeth Pune. She is a life member for several professional organizations, has presented papers at the national as well as the international level, and organized and attended various conferences and workshops, and she has published several papers in national as well as international journals. She's a PhD guide and ethical committee member and advisory board member for several national journals. At present, she's working as a principal in Bharati Vidyapeeth College of Nursing, Sangli. Over to you, ma'am.
Am I audible?
Yes, ma'am. Yes, ma'am.
And can you see my screen?
Yeah, we can see.
Okay. Thank you so much, Preeti. At the outset, I want to thank SOMI chapter, Maharashtra chapter. It's a privilege to share the platform with Mrs. Mangala Joshi, who is a dear friend of mine, my classmate. And it's such a pleasant surprise to have her with me on this platform, as well as Madam Mani, who is my friend. She's my mentor, guide. So it's a great privilege. And I thank the organizer, especially Dr. Prabha Desila and team, for giving me this opportunity to share my thoughts on this very, very important topic, which is given to me, that is ethical dilemmas and practical problems faced by midwives. When the word ethic comes to our mind, I think all of us get a bit of phobia because it is connected to many things like morality, integrity, honesty. So all these words are connected to ethics. So since maternity nursing is an exciting and dynamic area of nursing practice, with that excitement, there comes issues related to ethical challenges, high rates of litigations in obstetrics, and the challenges for practicing safe and evidence-based nursing care, which is responsive for the needs of the women and families. Ethical issues arise every day in healthcare, and everyone has a role to play in ensuring the ethical delivery of care. Healthcare givers, particularly the midwives, face ethical issues, possibly because of their interaction with their clients in the reproductive age group. Now, let us understand what is ethical dilemma, or what is the ethical dilemma. It is a choice that has a potential to violate the ethical principles. I want to emphasize it is a choice. It is not that a person doesn't know what are the ethical principles, but knowingly they choose to practice which may not be right. So a dilemma has been described as a situation requiring choice between what appears to be and or undesirable alternatives. And it also can be described as a situation in which the client's rights are overlooked. Okay, so this is ethical dilemma, to choose between what is legal and what is illegal. So ethical dilemmas occur in maternal and child health nursing as they do in other areas of nursing. Such situations are common in perinatal and neonatal care because the well-being of mother and her neonate must be considered. As we all are aware that there are rapid technological and scientific advancements. So these advancements, sometimes they present difficult questions for the midwife, where she has to choose what is right for and what is beneficial to her client. Ethical issues across the childbearing ages are multiple. They are very complex. Professional code of ethics are largely designed to protect clients' rights. Lindgren defines ethics as rules or principles which govern the correct conduct and social values. Each practitioner, when each practitioner enters the profession, that particular practitioner is given certain responsibilities to adhere to the standards of ethical practice and conduct which is set by the profession. We all know that the nursing profession is governed by such code of ethics, and we are expected to maintain certain standards when we are practicing, which is mandatory whether you are a midwife or whether you are nurse. So these principles are to be kept in mind when we are practicing midwifery also. So ethical and social issues affecting the health of pregnant women and their fetus are increasingly complex. Some of the complexity arises from technical advances in reproductive technology, maternity care and neonatal care. We must not forget that nurses are autonomous professionals who are required to provide ethically competent care. Ethical issues and challenges in maternal and child health nursing. Maternal and child health issues often involve conflicts in which a woman behaves in a way that may cause harm to her fetus or is disapproved of by some or most members of the society. So it's not only the midwife who faces the ethical issues, sometimes it is a pregnant woman who also could face such ethical challenges, and it is the midwife who should help the mother to deal with these challenges. And for that, midwife needs to have constant interaction with the mother. She needs to create the rapport, and she needs to help the mother and the family to deal with these ethical challenges. So conflicts between a mother and fetus occur when the mother's need, behavior, or wishes, they may injure the fetus. So these are the situations where the mother requires help, and it is there the midwife's role is very, very important to help the mother to deal with these kind of conflicts so that she doesn't harm her baby. She doesn't harm her fetus. The most obvious instances involve abortions. These are few of the situations where ethical dilemmas can arise, and a midwife may have to face the ethical dilemmas in this kind of situations. So these are few examples like abortion, assisted reproductive therapy, like artificial insemination, in vitro fertilization, and embryo transfer or surrogate parenthood. Selective reduction in multifetal pregnancy in treatment for fetal conditions, substance abuse, and refusal to follow the advice of the caregivers. So these are the situations where the nurse or the midwife will face ethical dilemmas. She really requires proper training. She requires definite skills. She needs to be aware of these situations if she has to deal with them. Healthcare workers and society may respond to such women with anger rather than support. So this is where it doesn't matter how the society is reacting to the mother, but then the nurse or the midwife is the counselor. She's there to support the mother, and when she's dealing with this kind of situation, she should remember that the rights of the mother and fetus should be kept in mind as she's giving quality care to the client. Nurses need to clarify their own personal values and beliefs on certain issues and must be able to provide non-biased care before assuming responsibility. Now, many times the situation may come where her personal values and beliefs may be different, but the midwife has to keep in mind that her own personal values and beliefs should not affect her care. Otherwise, it will become a biased care. So their decisions to care for or refuse care for the client may affect staff unity, influences staff decisions, and challenges the ethical concept of duty. So she must remember, as a midwife, she's a member of a healthcare team. So whatever are her personal values, it should not affect the ethical concept of the team. Nurses need to make their values and beliefs known to their managers before the situation occurs so that alternative staffing arrangements can be made. This is very, very important. A midwife or a nurse cannot refuse last minute taking care of a client because it doesn't agree with her value and beliefs, because then this will put her managers or the nursing heads in a very difficult situation because they will have to make last minute alternatives. So it is better that she informs about her values and beliefs before in hand, so that alternative arrangements can be made. Open communication and acceptance of personal beliefs and others can promote a comfortable working environment. Nurse needs to understand laws and the conflicting beliefs. It is very, very important that because of Consumer Protection Act, and there are many laws which are coming into existence, our clients are more aware of the legal aspects. So we as midwives or nurses must understand legal aspects and the conflicting beliefs. These are some of the situations, as I have said earlier, that because of advancement, there could be some situations where these ethical dilemmas may occur. So one of them is fetal therapy. So this is becoming very, very common as the techniques are improving day by day. So example, intrauterine blood transfusions, these kind of practices are coming into existence, fetal surgeries. So these are the areas where some midwives or some may argue that medical technology should not interfere with nature and this intervention should not take place. But keeping in mind the health of the mother and the health of the baby, sometimes we should not waste our time because these are the subjects of debates, intellectual discussions. But for nurses, the procedures are part of their daily routine. So it should not affect the quality care or the midwifery care. The use of technology grows, situations will surface more frequently, which may test midwives or nurses' belief system. So encouraging open discussion to address emotional issues and difference of opinions among staff members is healthy, and it increases tolerance from different point of view. So open communication is very, very important. And never forgetting that you are a very important part of a team which deals with the mother and her baby and also with her family. So open discussion is one thing which she is which will help her to overcome many dilemmas. Another situation could be informed consent. We all know the value of informed consent. It has 4 key components: disclosure, comprehension, competency, and voluntariness. So many times a situation will come where the midwife may not have time to take consent, or it is like dealing with the patient's or the client's life, baby's life. So there the role of standard operating orders come. So but she must remember that all adults above the 18 years of age should be given opportunity, and a proper consent has to be taken, because if proper consent is not taken, she could be accused of charges of assault, and then that is going to cause legal problems for the midwife. So consent is one area where she may face the dilemma. And then the children who are minors, she must remember that consent to be taken from this may not happen in midwifery, but as a nurse this may happen, that she may have to take consent from the parents. So she needs to be very, very familiar with the policies related to consent, and treating clients without obtaining proper consent may result in charges of assault, as I have already said, and the healthcare provider or a midwife may be held liable for any damages, and she has to be very, very careful in this area. Now, the client who cannot provide consent, in that case, she will have to take consent from the legal guardian. It could be a parent, it could be anybody who is considered as legal guardian. And in case of emergency, if she is taking consent over the phone, it may be allowed the consent over the telephone, but most important thing, there should be 2 witnesses who should be listening simultaneously And these two witnesses will have to sign the consent form indicating that the consent was received via telephone. These are some practical issues which we have to be very, very careful. Sometimes what happens, we want to save the life of the mother and the baby, but nowadays the Consumer Protection Act, and there are so many laws which are protecting the client. We have to be careful and we should be aware of the legality of the care. Another situation where dilemma can occur is refusal of medical treatment. We must not forget as midwives that all clients have the right to refuse medical treatment, and it is important to educate the client and family about the importance of the recommended treatment without forcing them to agree. This is very, very important. Sometimes what happens is that refusal to treatment is mainly because there is a conflict based on families' religious or cultural beliefs and the healthcare team's recommendation. So this is where we need to educate, we need to act as a counselor, we need to spend time with them. We should try to convince the client that how important it is for them to undergo this treatment. But at the same time, we cannot force any treatment. We cannot ask them to agree with whatever treatment is or care is advised for them. Confidentiality is one thing, one situation, one area where midwife has to be very, very careful, and she has to maintain confidentiality because there are many issues related to confidentiality where she can face problems. And the confidentiality of healthcare information is now mandatory by law. So she cannot disclose without the permission of the client and the family. Now, fetal injury is another area where I have already said that some of the mother's actions may cause injury to the fetus, and the question of whether she should be restrained or prosecuted has a legal and ethical implication. It is not for us to decide. The law will take its own course, but then as midwife, as a nurses, we must prepare the mother so that she doesn't injure the baby. In an ethical dilemma is a difficult moral problem that involves two or more mutually exclusive, morally correct causes of action. A nurse may not be sure of what action to take when in dilemma. This is very important, that she's confused at times when she's in dilemma, and she will not be able to take a proper decision. So let us see what are the steps in ethical decision making in nursing and in midwifery. The first step is identify the process or clarify the ethical dilemma. This is described as identification of the problem. Second step, the questions posed may include whose problem is it, what is the goal, who should make the decision, who is affected by that decision, what ethical and moral principles are related to the problem. Thirdly, third step, gather additional data to analyze the causes and consequences of the problem, get as much detailed information about the situation as possible to enable you to make an informed decision. Fourth, describe the situation that gave rise to the problem, main people involved, their views and interest, client's overall nursing, medical, social situation, relevance or relevant legal administrative staff consideration. Fifth, explore optional solutions to the problem, identify options, identify all possible courses of action which are open to you. And sixth step is make a decision. Think through options identified. Some will be feasible, some may not be visible. So determine which option is acceptable to you. When you are making a decision, remember the best decision is regarded as one which is consistent with one's values, which does not involve risking one's life or violating laws. I think in midwifery, this is very, very significant, that it should be going with the value of our client, of our families. It should not violate the laws, and it should also be related to professional ethics. So all these aspects will help you to make a best decision. And lastly, after deciding what decision you have taken, implement that, implement the selected solution or selected decision. Carrying out implementation is very, very important. Most of the decisions remain on the paper. Unless you implement, then it is not going to help your client. So for this implementation, you need collaboration with others. You cannot work alone. You need collaboration with other members. So communication of your decision or involving other team members in decision is the best thing that you can do as a midwife. And only implementation is not going to help you. So you have to evaluate the results. So feedback mechanism is very, very important. After implementation, you will always have to see whether your decision, what was the impact of your decision. I'm sure none of us are perfect. So we still are learning. So whenever you are taking ethical decisions, you need a feedback, you develop a feedback mechanism which will help you to overcome the weaknesses that occurred when you took the decision. If you simply remember this word ethics, so this is going to help you. Okay, so I have just prepare a slide which will what I have said, whatever I have discussed now, the steps, these are going to help you if you remember the word ethics. So some of the helpful strategies in making ethical choices: know your values and professional values, and do not compromise either. This is very important. As a midwife, we know what we believe in, personally as well as professionally, and never compromise on those values. This will give you confidence, and it will help you to practice honestly and in a committed ways. Recognize your accountability. See, most of us forget our accountabilities many times. So we should not forget our accountabilities, professional role as a client advocate. And we also, after knowing our responsibilities and accountabilities, we must know how to prioritize our responsibilities and accountabilities. It is not that we are accountable only to clients, we are also accountable to other team members. I already said that we must have a good collaboration, and we must negotiate with others to sort out the challenges of care. One very important thing I would like to emphasize here, that ethical judgments do not rely on emotions. It does not rely on the emotions. Many times we take decisions based on emotions, which could lead to a wrong decision making. So remember that ethical judgments do not depend on emotions. They are based on sound knowledge, and we should remember this, that never take decisions based on emotions. At the same time, do not feel disappointed that not everyone meet your standards. So it is not necessary to get disappointed as long as you know what you are doing. You are very sure about your personal values, and you are contributing your best to the team. There is no need for you to get disappointed. Everybody cannot appreciate what you are doing. Everybody will not be appreciative of your work, what you are doing. So what is the role of a nurse in ethical decision making? These can be summarized as: identify ethical practice, advocate on behalf of mothers or families, inform and involve the clients in ethical decisions, participate in informal processes that address ethical issues, and keep on evaluating. Remember, evaluation is a continuous process, so keep on evaluating. Now, the next half of my talk, challenges faced by midwives. I'm very grateful to Dr. Usha Ukande. I had a discussion with ma'am, and these are few points which madam have given to me. So I would like to present these points, that challenges faced by midwives in India. A few points for concern. Preparation of midwives at A&M, GNM and BSc nursing are different, whereas their work with mothers and newborn is similar. The quality of practical training in midwifery is questionable. Just now, Madam Mani said that practically the students don't get opportunity to practice midwifery. They do not conduct labor cases. So INC has advised that at 4th year BSc level, they must conduct 20 cases. We know practically what happens, and just for the sake of completing the requirement, sometimes one case is shared by 2 to 3 students. This is really a very, very pathetic situation. We have been telling that reduce the number of cases, but at least see that at least each student gets time, gets opportunity to conduct at least 5 or 10 cases individually. So we really need to work for this. Midwifery has been taught in the lines of OBG based on medical model instead of midwifery model. Therefore, the RN when starts working in a maternity department based on her education and practical experience, takes care of pregnant and birthing women just like an assistant to an obstetrician and not like a fully responsible midwife. Midwives in hospitals are not expected to make any decisions in collaboration with the mother, as is the train. Doctors make decisions, midwives and women have to follow them. This is very, very sad. I had a visit to Sweden and I have seen how independently the midwives work there. Actually, the obstetrician does hardly comes to maternity unit. The midwives take independent decisions and there the preparation or the training is altogether different. They have 3 years of basic course, nursing course syllabus, and then they have 2 years of training for the midwives. So it is actually they prepare the midwives to work independently. Ethical dilemmas for midwives, sometimes knowing well that the doctor's decision is not in the best of the interest of the mother, yet she quietly follows the order. And there are many such occasions in our country, in our state, and we know that sometimes nurses cannot voice out. I hope a day will come where the midwives will have the opportunity to take independent decisions. Challenges are many, and we need to start from the beginning, preparing the midwives well to take full responsibility of taking care of women in their complete reproductive cycle. And we really will have to work towards this goal. Now, these are some of the challenges faced by the midwives in Maharashtra and in India. Shortage of nurse midwives. We all know that there are shortage of nurse midwives. Improve the working environment, salary structure, career progression. I'm not going to deal much with strategies because Dr. Supriya Putil will be dealing with the strategies to overcome the challenges. So the first challenge, apart from what I have said, the additional challenges, shortage of nurse midwife, inadequate resources in health facility, because we need resources to maintain quality care. So there are very inadequate resources which will help us to maintain the standard of care given to our client. So there is commercialization of this section, midwifery section in some of the hospitals. We don't have adequate funds. So to get adequate resources will help us to give evidence-based quality care. So strategies I'm omitting. Then gender inequality and traditional practice beliefs. So I think we need to overcome this problem. Involve male partners in maternal and child health services. Traditional leaders can be enlightened to pursue men to get involved in care of their wives and children. So I think this problem has overcome to certain extent. We know that nowadays we have more male students than female students. And of course, in BSc nursing, they practice midwifery. So to continue with the challenges, there are social challenges. We know that there is insufficient education, especially in India. The clients with whom we are dealing with, they don't have much of education. So sometimes that could cause problem for the nurse, for them to understand what she's trying to tell them, the education that we are going to give them. If our clients were educated, still we may not face much of the social challenges. But of course, the situation is improving. There are clients who go to internet and then they come prepared. So the situation is 50-50. Lack of well-functioning of referral system. We really will have to work for this. The collaboration between the hospital and community, still the referral system is not well advanced, or it is not functioning that up to the standard. So still the referral system will have to be improved to overcome these challenges. Then there are shortage of necessary facilities which are needed to provide good obstetric care. Feeling of demoralization, this is very, very important. The appreciation which should be given by the client as well as by the co-workers, as well as by the seniors, by the supervisors, we don't see much of it in our area. So there is feeling of demoralization. This itself is a biggest challenge for the midwife. If she has to give a quality care, she herself needs to be motivated. Her morale has to be very, very high. Then only she can give a good care. Otherwise, her care will be affected. Then the midwife has her own personal struggles like workload, stressful situations which may affect her own personal and family life. So she has her own personal struggles. So this is one of the challenge which she will have to, which she faces, and she will have to find strategies to overcome this challenge. In conclusion, ethical issues across the childbearing ages are multiple and complicated. Nursing is a process that involves judgment and action, with maintenance, promotion, and restoration of balance in human system. The need for judgment and action brought about the moral questions of right or wrong of duty. The end purpose of nursing is welfare of other human beings. Midwifery is 1% occupation, 99% it's a dedication. Believe you can, and you are halfway there. So as a midwives, we are facing with many, many challenges, many ethical dilemmas, but if we believe that we can overcome them, then we are halfway there through. And with other strategies, I'm sure we will achieve our target. We will reach to our destination. So if you have any queries, thank you for your patience listening. I want to thank the organizers. And this is my college, this is my hospital, a very beautiful campus. I invite you all sometimes whenever you happen to come to Sangli, please do visit. Thank you.
Thank you, ma'am. I think so there is a query which is given in the chat box. That is, what are the ethical challenges a mother will be dealing from? I think so you have already explained the ethical challenges.
Yeah, see, sometimes there are some personal cultural beliefs which the mother may have, but then because of family pressure, she may not be able to practice those beliefs. Okay, so this is what happens. Say, for example, very common in India, giving birth to a male child. So a mother may have to undergo abortion just because the family wants a boy. Okay, so these kind of dilemmas she will face, that she doesn't want to abort her baby, she doesn't want to lose her girl baby, but then because there is a family pressure, she may have to face this kind of dilemmas. So this is very common, what I have seen from my practice.
Okay, thank you, ma'am. Any queries? Anybody is having any queries? You can ask madam now. Okay, I hope there is no queries. So we thank you for this elaboration sessions, and we remember that the values of the client is important to make any decisions, as well as the making decision. This is not emotional things. You are not supposed to do any decisions in the emotional things. Thank you, madam. Thank you.
Thank you.
Now our next speaker for today is, there is little change in the structure. That is the Madam Sujata Sawant. She will be telling her experiences before we move on to the next sessions. Sujata ma'am is having 25 years of experience in the healthcare system, as well as in the nursing administration, nursing education, advocacy in maternal and child health. And madam has completed her PhD from Krishna Karad, and she has done her lactation education certified by Begin in India and approved by the Lactation Education Accreditation and Approval Review Committee USA. She's working with community at Navi Mumbai Municipal Corporation and the outreach activities organized by the Navi Mumbai Municipal Corporation. Next. Madam has a lead trainer for the ASHA workers, Anganwadi workers at NMMC, and presently she is training ANMs. And she has undergone various courses and training programs under the government of Maharashtra, and she is acting as a trainer for various projects. She has worked as nursing superintendent, nursing consultant, quality coordinator, trainer for ANM, as well as for various projects. Currently, she's working as certified lactation professional at Dr. G.Y. Patil Medical College Hospital and Research Center, Pune. Over to you, ma'am.
Thank you very much, Priti, for that elaborate introduction. Can you hear me? Hello? Can you hear
We can hear you, ma'am. We can hear you.
Yes.
Okay. So, it's going to be afternoon, but it's still good morning, everyone. As I go with my experience sharing, I would first like to present my gratitude to the ones who have helped me through this journey. As I was talking about my special thanks to Director Answers, Dr. M. Prakashama, for her support throughout the phase of conception and delivering my best practitioner of midwifery. Then Dr. Usha Ukande, she is there. She has always encouraged me to go for, and she has also helped me with the visit to her center in Chaitra Hospital, Indore. Then I'm thankful to Dr. Vijaya Krishnan, who is practicing midwife in Hyderabad, to visit the center and to guide me in my cases which I have undertaken independently. Then founder Birth India, Ruth Malik, because that is an organization. If any one of you are interested, you can log into their website and see various activities they do in human rights in childbirth. So Ruth has helped me join her organization even when I was not a member, when she realized that I am really passionate about practicing midwifery. Then my international and clients from India who have really trusted me with my competencies and allowed me to be their birth partner. So this is where I would also like to thank these organizers for allowing me to present my experiences to the coming generations of midwifery professionals in India. And definitely, as Madam Mangala Joshi has said, so many an answer hard to make midwifery a dream come true for everyone who is passionate about supporting normal births. They are inseparable entities of. Also, I would like to mention Zoe, who has helped me getting the international clients for birth. She was a student midwife then. She is taking her training from the US organization for becoming a practitioner, nurse practitioner in midwifery. Then Dr. Evita helped me. Hello, can you hear me? Yes. Any problems there?
No, ma'am. We can
Hello?
hear you. We can hear
Yeah.
you, ma'am.
Okay. So so far I have conducted 3 home births and attended, witnessed, I can say, not attended, but definitely witnessed 1 free birth and supported mother during their antenatal and postnatal journeys. All these mothers had a very traumatic experience of their previous births, or maybe they had a bad experience of the professionals whom they have gone to earlier. Like we all know that we have certain high risk parameters very well placed in our country. Certain age of mother is a high risk. Then mother goes beyond a particular parity is a high risk. And when you come to foreign clients, they don't really believe in that because for them, 3-4 births are normal. For them, a birth after 35 years of age, first birth of their first child is a normal thing, which we don't consider as a normal. We consider it as a high risk. And that's how the help of a midwife or there is a community of birth professionals known as birth doulas. They help these mothers to get into what they really expect of this birth. And as Madam Nilima has already told you that your values and your morals cannot come in between you and your practice. So whenever you have a client, you have to talk to them very freely about what is their concerns. You have to clearly make them understand that they are coming to a midwife and you are not a medical doctor. And the limitations of your practice according to the law of the nation that you have, and alongside care, what we talk about. Maybe Usha Madam is talking about that in her presentation later, so I'll not go into details. So this is what is certain things that you have to keep in mind if you are really planning to set up yourself for a independent practice of midwifery. First thing that I would like to tell you about, it is a lot of updation that we need because sometimes we are in teaching, sometimes we are in clinicals, and then when you are coming out of that particular profession, which is completely stable earning source for you, you have to first think about your finances. And second thing, you have to think about what are the other specializations or maybe skills that you need to take up as you start with your practice. Like Madam said about legal and ethical issues that you may face, the skills of managing the emergencies, because though births are considered as normal, they are very much considered to be a spontaneous onset and happening on their own physiological way. There are certain situations where they turn to be a nightmare. And you have to first ask yourself, if that happens in my client, am I prepared? Am I prepared to handle that situation? Am I prepared to face whatever comes in my way? Am I able to save the life which is handed over to me, considering that my hands are safe and I'm competent enough to take care of that? So this is what you have to think about. Then, of course, you have certain limitations of prescribing medications, and then also getting those medications is also a little limitation thing. Like you cannot really prescribe, administer oxytocin, prostadine, or misoprostol without any medical supervision. So that is the risk that you have here when you are practicing independently, and that's why if you are going for a non-clinical practice, it is much safer than going for a clinical practice. But since I was into midwifery for a longer duration with my clinical experience, I thought of venturing out on this particular thing. So these were some of the challenges, but there's nothing to scare if you are really committed and you will get through the ways. That is what we always talk about, that where there is a will, there is a way. And nurse practitioner in midwifery has already been rolled out, and we have been training going on for the third batch of trainers of midwifery, and lot many things coming out there. So it is going to be coming a much easier path than the earlier ones. And when you have passion, your passion becomes your energy. And that is what I have also felt when I started my practice. Of course, as I told you, there were certain tough decisions that I had to make on my finances, then family background and social avenues, as Madam has already mentioned. But I was ready to take that all risk, and with those little avenues of investment, whatever I had, I tried to give my best services to my clients. Of course, 2 home births which I have conducted. One was a family of a traditional practitioner, and they had some contacts with their family physician. So in case of emergencies, somebody was there to support me. That another thing which I would like to tell you about is the time. And whenever you take on the autonomy, you have certain responsibilities, and that you cannot really let go. So sometimes the birth I have witnessed to 16 hours, sometimes it is 18 hours and plus. You have to be there with your client. You cannot leave because it is not a hospital setup where you can hand in over your case after 8 hours to somebody else and then you go. It was my own practice, so I have to be there till my client completes her birth and then is bonded well with her baby, so that there is complete care that when we are talking about comprehensive care, that is done completely from my end. So the time limitations and family responsibilities also you got to consider when you are really looking for it. And sometimes, yes, of course, backing up by the medical professionals, which you think that they will be supporting you. That also I have seen some cases when I have taken a case and then we had discussed with a medical professional and they have agreed to provide the intermittent checks on the case so that whatever medical conditions are there, they are ruled out and the mother is going through a complete medical workup. Sometimes I have seen them backing up because I'm a midwife and they are not really comfortable working with a midwife as an independent practitioner. So these were the cases. But then I have learned one thing from there, that when someone says that, yeah, you cannot do something, you can do it else, or maybe we will have a next case with you, then maybe it is the time that you understand that what they try to mean is nothing that they can do for you now. And that was interesting because their backing out helped me become more committed to my goals and proving myself with the best practices and getting more and more referrals from the area where they practice. So that was really not so red carpet welcome. But when you are determined, things fall in place, and that has happened with me also. And I had interactions with my professional colleagues who also wanted to come along with me, and they have also shown interest in the practice of midwifery. But when we discussed and when we thought that we will come to a conclusion point and we will start up with our own setup, then that whatever they wanted to do was in their own sphere of job, where actually your identity as a midwifery professional is masked by your institutional identity. And that is a demarcated island which I was not comfortable to work with. Of course, many of us strive and work for various goals of our life, and I have no complaints about it. In fact, I don't want to say any, I don't want to comment on that particular background because everyone has a different perspective of life. But what I feel today is I am thankful to them for at least being there with me during that phase where I was really falling apart from the profession. And I now feel that Indian Nursing Council, TNAI, or the National Nurses Association, Society of Midwives, or maybe Birth School India and Birth India, various organizations which are really working for human rights in childbirth and the professional rights as INC and TNAI is concerned. They should have made it possible to legalize the practice of nursing and the practice of midwifery in India, because we have started so many specialization courses without giving any practicing rights to them. Still, we have panelists who speak about many things, but then still they have been confusions about whether I can practice independently or not. Yes, of course, we can practice independently. We are registered nurses and registered midwives. We are licensed to practice in our country. That is what our definition says. But yes, of course, as we have discussed earlier and the legal and ethical issues have been discussed, we have been given certain privileges of a particular level of education that we take, and we must understand our limitations. And we should not cross the boundaries of what we are privileged to and what we are not privileged to are not expected to be done by us, because that is a fine line between what you can do and what is anticipated out of a particular situation, which may not be in your purview, where you definitely need a support from the medical professionals. So what I would like to say is that you just cannot take up everything in a rivalry. Yeah. Yes, but of course you have to prove yourself to the your rivals that you are also equally competent in whatever you do, and you are educated, you are skilled enough to take up the task which you are longing for and you are going in for. So your experiences, documentation should be very well done. Your dealings to do whatever you are doing with your professional colleagues should be very clearly mentioned. And of course, as we have learned about the legal issues, there is something called as birth plans or the plan of care, which needs to be well documented, which needs to be signed by your client. Maybe if they are asking for that, member, whoever they are willing to be partnering with for their entire, and then they need to be countersigned by the backup team of wherever you are working as a birth professional. So then that becomes a legally undocumented care plan, and you have to stick to that. And as Madam Nilima has said, that if there is any change that you have to make, you have to take consent. Without consent, you cannot even touch mother, or you cannot interact with their family members without their consent about what is happening to the mother or what decisions you need to change or what is the plan that you need to change. It's first the client with whom you are primarily attached to that you have to inform about the happenings, whatever is there. And then with their consent, you discuss with the family members and then the third person, whoever is expected to take care of that particular event there onward. So this is very clearly we have to follow in practice, and disclosures that you are a nurse midwife and this is what is your limitations of practice, what you will be requiring, whether mother will require any blood transfusions, if it is a case of vaginal birth after cesarean section, if she needs a operative intervention, then which is the hospital that she needs to choose, which hospital has which gynecologist or obstetrician to whom she would like to go, and then at least having one visit with that person so that they are familiar with each other, and then she knows the setup. So all these things matter a lot when you are practicing independent. I hope I am taking care of everything here. Yes, definitely. If you ask me about what challenges I faced is, and what challenges I faced is I told you about. But yes, of course, what improvements that I would like to happen is the help from the government to legalize independent practice to existing nurses and midwives, as they are allowing us to conduct births when we are working with the government setup. Like the ANMs, when they are placed in a remote area where no doctor or medical facilities are available, then they are conducting home births where no one can reach. So if that is the case, if someone wants to do it with a well-set institution, or if someone who is registered and licensed to practice from a nursing and midwifery background, I would request the government to look into their private practice arena as well. Because this is a lot more workforce that will be equipped by them, that can be utilized by them, where
Hello,
they really.
Sujata ma'am.
Yes, I'm
Yeah,
finishing
time.
with my.
Yes, ma'am. Okay, ma'am.
Okay, just give me a minute and I will close. And then council should start with a separate education for general nurses and midwives, and the syllabus needs to be revised with privileging of practice. So that will help them to understand where they are standing and where they should look into. Then incorporating the standards for midwifery course to the postgraduate courses from the current academic year onwards. Because if you want the midwives to be trained with ICM competencies and give their 1.5 year other than their post graduation, then it is, I think, ridiculous, because you are certifying them to be a postgraduates and masters and doctors in particular field, and then you are asking them to undergo 1.5 years or 18 months training as a midwife. It is really ridiculous. That means you're not sure of whatever education you are imparting them, making them competent. So, as with this, I will stop. And if you
Ma'am, your
can
voice
take
is
it.
breaking. Ma'am, your voice is breaking.
My voice is breaking, PV?
Now it's
Sorry.
okay. Now it's okay.
Yeah. So that is what I was trying to tell, that if the government and Indian Nursing Council takes it in a right spirit, as we have started with NPM, I feel the postgraduate nurses who are going through the obstetrics and gynecological nursing, that nomenclature should be scrapped and they should be made as midwifery professionals. And those who are interested in gynecology, of course, they can be going for gynecology, but it should be only exclusive gynecological practice. Those who are going for midwifery should be trained with an ICM standard, so that they are not wasting their years of life, and it adds more value to their education than going on repeating the same thing from the BSc level to postgraduate and postgraduate to another levels of education. So it's just waste of their years and waste of their money, I guess, and that should be stopped with it. That is what is my request to the government and the council representatives who are present here. Thank you.
Thank you, ma'am. Sharing your vast experiences as well as giving us the option what all things we can do and how independently the nurse can work with. And for the participant also, if you have any queries, anything you want to ask or any help is required, you can always approach Dr. Sawant ma'am. She's working as a consultant in Divai Patel Hospital, that is Pune. We'll move on to our next session now.
Yes.
The next
Maybe
session.
I will take a.
Yes, ma'am. Yes, ma'am.
Thank you. Yeah. If you have any questions, you can drop me on my mail.
Yes, ma'am.
I will reply them.
Yes, ma'am. Our next speaker is Dr. Supriya Potal Ray. She completed her BSc and MSc and PhD nursing from Bharatiya Vidyapeeth University College of Nursing, Pune. And she's a gold medalist in MSc Nursing and member of College Research Cell as well as the member of Research Advisory Committee in Bharatiya Vidyapeeth University College of Nursing, Pune. She's a life member of several professional organizations, presents several papers in the national and international level, organized and attended various conferences and workshops, and has published several papers in national and international journals. She's contributory to the author to the 2 books, as well as the master trainer for GA, ATM, IMNCI, as well as NRP. At presently, she's working as an assistant professor in Bharatiya Vidyapeeth College of Nursing, Pune. Over to you, ma'am.
Thank you, Preeti, for the wonderful introduction what you've given for me. I hope I'm audible to all.
Yes, ma'am.
Yeah. I bring greetings to you from Bharatiya Vidyapeeth University and Bharatiya Vidyapeeth College of Nursing, Pune. And I would like to thank all the members of the organizing committee, SOMI, and MGM, New Bombay College of Nursing, for giving me this opportunity to share my views on the topic of strategies to overcome the practical challenges. Before I could go into the topic, I would again like to thank all my mentors, my teachers, and I feel privileged to share this platform. I have Mani Madam on board here, Madam Shri Priya, Madam Nilima Bhure, who has been my first midwifery teacher and my PhD guide, and Professor Praveena Bhadalkar. So probably what I share today, it is because of the teachings of all these great stalwarts into the field of midwifery. Can we move on to the next slide, please? Can I have the next slide, please?
One minute, ma'am.
Yeah, sure.
Yes, ma'am.
Yes, correct. So we're talking about what could be the practical challenges and how we could overcome that. And for that, we need to really know, or we need to see what a midwife would possess. She has to be compassionate. She has to be an expert in her art, and she needs to be smart. She needs to be caring. She has to be dedicated. And there is another quote which says, "A midwife must possess the hand of a lady, the eyes of a hawk, and the heart of a lion." So if we really need to have all these qualities, we need to think about the kind of strategies we need to go forward with to the challenges what we face. Madam Nilima had tried to tell us a bit about what could be the practical challenges and how we would try to overcome that we're going to see in the next few slides. And the next one, please. So strategies, when we say strategies, what do we mean by it? Are they the goals? They're not the goals, but they are the pathways for which we could reach. And then we have many strategies. We need to really ideally think and pick up each one of these strategies so that we need to fulfill what the ultimate goal of a midwife would be. Next slide, please. Challenges, we all know that the year 2020 had been designated as the International Year of the Nurse and Midwives. Though it has been proclaimed to be the International Year of the Nurse and Midwives, there are still many challenges which we need to overcome, and we need to blossom them into opportunities which can help us to furnish our skills and to provide quality care. Next slide. So if you can see, it looks like a kind of a jigsaw puzzle which says, which has words like teaching, e-learning, quality, excellence, motivation, facilitation, being a role model, leadership, innovation. Now, all these things which are into a jigsaw puzzle has to be put into a sequential order so that we know where do we overcome all these challenges. Please. Can I have the next slide? Why talk about it? Because we need quality of care, and we know the ultimate aim is to reduce the maternal and the neonatal or the newborn deaths. So therefore, we need to have an integration of educated, trained, regulated, and licensed midwives into the health system, so that in association with all these, we can provide improved quality of care, and this will help us to sustain and decrease the maternal and the newborn mortality and the morbidity rates. Next slide. There is a quote which goes as in midwifery education and practice is the bedrock for equipping midwives with appropriate competencies to provide high standard of safe and evidence-based care. So again, it comes down to the kind of training, the kind of education, the kind of practice, what is needed, and how the midwives are trained into the future goals, and how they practice whatever is being taught to them. Next, please.
Participants, kindly mute yourself.
So we are going to see now the strategies which have been listed down or which has been propagated by the WHO and the other societies of midwifery education and practice who have laid down these strategies, and we need to follow them in order to fulfill our goals. Next, please. We're going to be talking about this. Our goal, so that all women of all the reproductive ages, including the adolescents, they have universal access to midwifery care. And this quality midwifery care, it has to be scaled with availability of the resources, accessibility of the resources, and the quality of midwifery workforce. We have certain guiding principles which will help us to attain the goal into midwifery care. First is the ethical action, and we have seen the kind of ethical dilemmas which nurse midwife would face into her practical or into her practice. The relevance of her practice has to be discussed. The ownership as to how she is going to deal with it, leadership qualities, what she needs to possess, and the kind of partnerships she needs to achieve or she needs to build up. And these principles will help her to achieve all the strategic plans and the decisions what have been laid down. Next, please. We're going to talk about these strategic decisions or the plans. The first one is governance and regulation. Second one being quality education and training, workforce management, practice and service delivery, and evidence and research. When we talk about these particular decisions, there are certain directions which lead us into adopting and into practicing the decisions which have been propagated. We need to identify the problems first in accordance, seek information related to those problems. We need to have certain brainstorming sessions to identify the kind of strategies which we would adopt. You need to choose alternatives because there would be many kind of situations or many kind of possibilities which would be there in front of you. We need to implement the plan of what we're going to choose from the alternatives. And finally, we need to evaluate the outcomes, which will help us in attaining the directions what we plan for. Next, please. Can I have the next slide? So into governance and regulation, what are the things we look out for? The midwifery workforce, it has to be regulated through regulatory bodies, and we need authorities who can take up the responsibilities for developing, maintaining quality midwifery services, and to respond to the population of the health needs. We're not saying that we do not have the regulatory bodies, but these regulatory bodies need to prioritize certain areas in defining the scope and practice of the midwife, strengthening midwifery management structure, and strengthening or to introduce the national and international midwifery regulatory processes. Next, please. Under quality education and training, we need a robust midwifery education and training programs, which produces adequate number of qualified midwives, what we've been talking about, to bridge in the gap between the theory and the practice. And we need to be well equipped with the basic midwifery competencies. There are certain kind of continuing programs and development which have to be included in-service training, which enables the midwifery workforce to maintain the up-to-date skills as well as knowledge. In prioritizing these areas, we need to think about strengthening capacity to develop and maintain the midwifery education, build capacity of the faculty to deliver quality midwifery education and training, and to develop and strengthen the continuous professional development. Next, please. The third kind of a strategic decision is required in the workforce management. So effective midwifery workforce planning and management ensures adequate numbers and distribution. So promoting skill mix in interdisciplinary teams, which will enable for effective use of available midwifery expertise. And we need to have a wide range of providers of midwifery skills who are engaged in providing midwifery services, and these services which have to be along with the broad spectrum of reproductive, maternal, neonatal, child and adolescent health, and to ensure the continuum of this particular care along with the two dimensions of place and period. So the kind of workforce or the kind of effective midwifery workforce planning has to be in accordance to all these particular areas, right from reproduction, including maternal, neonatal, child, adolescent health. The priority areas then which have to be covered under the workforce management would be ensuring that the country has a national policy and plan for midwifery workforce embedded with national and international health workforce plan. And we need to have a certain standard indicators and to invest in increasing capacity of the midwifery workforce. Next, please. Practice and service delivery. So in the midwifery-led continuum of care, there are two dimensions, that is pre-pregnancy, pregnancy, childbirth, early days, and the early months of life, and the place, the two dimensions what we were talking about. First was the period, and the second was the place, that is from home to the health facility and back to home. So these have to be integrated when we talk about practice and the service delivery. Prioritizing the areas under this would be ensuring midwifery-led continuum care at all levels, enhancing quality midwifery care, and promoting rights or the right-based midwifery approach for respectful care of the woman. And the last, into the strategic planning, or the strategic decision, it is evidence and research. So generating evidence and conducting research, supporting midwifery practice and education. We need to have policy making to respond to population needs and thereby enhance the quality of care. We need to conduct researches which generate the evidence. These evidences have to be translated into practice, and the practice has to be documented so that it would be implemented in policies at the hierarchical levels. Priority area 1, or the first priority area in implementation and monitoring framework of statistic decisions, we need to define the scope and practice of midwifery. There are certain actions which we need to take, or there are certain actions for all these priority needs, which we will be discussing in short. First and foremost, the action, we need to define who a midwife would be or who a midwife is. It's not that it has not been defined, but as it has been discussed by the earlier speakers, that A&M, general nursing midwifery, auxiliary nurse midwifery, basic BSc syllabus course, or a post-basic course, or MSc nursing course, or independent midwifery practitioner, everyone has the term midwife. So then if we need to have certain strategic decisions, we need to define who a midwife would be, what are the midwifery services which are provided, whom do we designate as midwifery workforce, what is the midwifery model of care, what we are talking about to change the syllabus from a medical model to midwifery model, and a midwifery-led continuum of care. Ensure that the word midwife is applicable only to recognized and licensed practitioner with the full scope of ICM competencies based on the country context, and to establish and to create a cadre of midwives with legal support to provide the full scope of the ICM competencies. We are all aware of the ICM competencies which have been listed down, and therefore we need to ensure that a midwife, or the term should be applicable only to licensed practitioners who actually practice with all these competencies and skills. We need also to prepare a framework for responsibilities and accountability of midwives, protocols for admission of midwifery into midwifery-led facilities, guidelines documenting care, which would be discussed into detail with the later on speakers, Accordingly, we need to prepare standards of practice, standards of instruction, guidelines, treatments, algorithms, protocols for referral, follow-up at each level and facilities from the community level. Next, please. We also need to have and to design, conduct orientation, reorientation of the training workshops across all relevant professional groups, which includes the nurses, midwives, nurse midwives, health workers, medical practitioners, and the most important point, that is, we need to explain it to the obstetricians and pediatricians on the roles and responsibilities of a midwife. Therefore, we need not be working under them, but we need to have our own protocols, and these the responsibilities and roles what a midwife would have and what she possesses has to be explained into detail. Professional associations, they have to take part in designing practice guidelines and disseminating them among members. There are existing guidelines, but many times it has been seen that these guidelines or the frameworks which have been planned, they are actually not, they do not reach up to the grassroots levels. Integrating the ICM midwifery service framework to strengthen the quality service across all the health systems. Next, please. We have certain indicators for monitoring these priority areas. That is, the statements, definitions are formulated and disseminated in the public domain. Standards of practice, standard instruction for treatment, algorithm, protocols, which we've already discussed, and the guidelines need to be, which are available for use, they have to be reviewed at all levels. A cadre of midwives is established, regulated, and deployed only for midwifery care. Practice guidelines are designed and disseminated by professional association in collaboration with the government, and countries have integrated the ICM and the MSFs to strengthen the quality of reproductive, maternal, neonatal, child, adolescent health services across the health systems. So these indicators are available for monitoring, and we need to bring it into action. Next, please. We move on to the next priority area, that is strengthen the midwifery management structures at all levels. Next, please. When we talk about strengthening structures at all levels, we need to ensure that the midwifery-based service units are managed by qualified midwives and who are professionally qualified at the facilities which are at all community levels, not restricting it only to the urban areas, but as well as to the rural areas, to the tribal population as well, because here are the places where these women are not even they're not able to even make it up to the rural hospitals or to the healthcare centers which have been provided. So such midwifery-led units services have to be established right up to the grassroots level in the community. We need to review the roles of the chief nursing and or midwifery officers and make changes to introduce the position of a chief midwifery officer so that all guidelines, all the protocols, all the action plans are formulated by the chief midwifery officer, who has to be a separate entity and not working under any banner of the medical profession. We need to establish, strengthen a multi-stakeholder national midwifery task force and have regular reviews for this particular task force, which has to be specifically designed for midwifery. We need to promote, collaborate between departments of RMNCAF and midwifery with Ministry of Health and other service sectors or the health sectors. Introducing management approach to upgrading capacity of the chief nursing or the nursing officer and other midwifery managers or the management staff to enable them to participate in policy decision making, and thereby they would be in a position to give input into the policy making. Ensuring that the decision making related to midwifery practice, it rests with these chief nursing or the midwifery officers. And definitely we need to establish a career progressive path for midwives, including management, teaching, research position within the midwifery and the RMNCAH and other sectors of the public health. So the role of a midwifery officer or of the chief nursing officer into midwifery, it has to be made into specification.
Take a minute, ma'am. Ma'am, kindly Soumya and Priyansha, kindly mute yourself. Ma'am, continue, ma'am.
Can I have the next slide, please? Can we move on to the next? Yeah, thank you. To monitor this particular priority area, we have indicators for monitoring. That is, there has to be specific department, directorate responsible for planning and management of midwifery workforce. There has to be clearly defined, mapped, and enumerated what the midwifery workforce would be like. As we've discussed, that the chief nursing or midwifery officers, they have to be introduced and strengthened wherever necessary. There have to be members and into the national committees for discussing the health priorities. Clear cadre and career pathways have to exist for midwives into the country. And the midwives are placed in management position at every level with the midwifery workflows, wherever the midwifery workforce is deployed. And a national midwifery task force is established and led by a midwife. So these are the indicators for monitoring the priority area for strengthening it at all levels. The third priority area is to strengthen, introduce national midwifery regulatory process for governing midwifery and into education and practice. Next, please. The actions here required is to have a regulatory body to ensure evidence-based and ethics-based regulation into midwifery education and practice. We need to have a distinct licensing system for midwives, separating it from nursing, and to formulate requirements and process for renewal. Right now, we do have a nurse midwifery licensure under which we practice, but it is along with the nurse, the registration of the RN and the RM. So when we talk about education and practice, we need to bring about changes where only we need to have a specific licensing system for midwifery. We need to review the current situation, regulations, the standards of midwifery practice, and there needs to be a reorganization. Midwifery needs to have an autonomous professional or profession standard with clearly defined roles and collaborative partnership with professional organizations. Therefore, there has been already an introduction, update, and support of the Midwifery Act. We need to establish and strengthen a national professional association for the midwives. Next, please. The indicators for monitoring have regulations and standards for midwifery practice, education and licensing, including an act to regulate midwifery practice. It has to be sanctioned to separate licensing from nursing, and standards and protocols available for practice at all levels. So these are the indicators for monitoring which has been worked upon to have a separate licensure for midwifery practice. Next, please. Priority area 4, to strengthen capacity to develop, maintain the midwifery education. We need certain actions to be deployed here. That is establishing criteria for clinical training sites that clearly follow the midwifery-led model of care to mothers and the babies. We need to have a mechanism for monitoring, evaluation, documentation of these educational programs. Our previous speaker, Madam Nilima, also said that we do have the number of deliveries to be conducted by the students, but how many of them do we actually conduct it independently? So therefore, we need to have review and update on the curriculum, which is based on the national standards of the ICM, which is competency based for the midwifery workforce by each institution. We need to strengthen a national accreditation mechanism for educational programs and institutions for quality or for the continuous quality improvement. Reviewing midwifery education, training across all the different levels, because we know we have got the different cadres of midwifery, and all of them, they provide a care to a laboring woman or to an antenatal woman or to the girls in the adolescent age group. We need to review and update process and methods for midwifery education, distinct from educational programs, which includes respect, choice, dignity of woman with basic midwifery education. We also need to update list of essential equipments which are based on national standards for skill or the skill laboratory, information technology facilities for each institution. We need to have establishment of guidelines for practical hours, the caseload, student-teacher ratio, method of clinical teaching, and the supervision. Next, please. The indicators, again, it remains the same. That is, we need to update with a relevant curriculum based on the elements of the ICM competencies. And there has been a change which has been brought about in the recent syllabus, which has been provided by the Indian Nursing Council. We have countries who have clearly stated the standards for midwifery education, accreditation, mechanism for educational programs, institution providing midwifery training are available, and these are widely disseminated. So the indicators have been started to be worked upon, and we can see a change in these particular strategies. Next, please. Priority area 5, we need to have capacity building for educators to deliver quality midwifery education and training. The action plan which is required awareness or to assess the educator competencies as per the WHO midwifery education core competencies. We have to evolve the the national criteria for selection of a midwifery educator, including qualifications and experience into practice and the teaching. So when we talk about providing education, we need to pay attention to the kind of midwifery educators who have been picked up or who are providing these particular education to the next generation. Expose the educators to midwifery model of care wherever available to encourage them to incorporate this within their teaching. We need to design and implement a competency-based midwifery education program as per the guidelines of the WHO and the kind of cases which each individual student gets, the teaching, the use of research-based evidence or evidence-based practice, principles of ethical practices, or updating the competency assessment tools which is available. We need to evaluate the midwifery educators based upon this particular tool. Next, please. We need to prepare, establish, strengthen the training facilities for midwifery educators. And we have to ensure that these particular midwifery educators, they are associated with and they provide services into the practical settings. We have to ensure that all the midwifery educators also practice in clinical settings and keep record of their practice in order to provide practice-based midwifery training. So when we talk about giving training, it is not only that we teach the students, but the faculty herself has to kind of have her skills polished when she teaches or when she is into a teaching-led unit. Streamlining the practical teaching methods specific to midwifery education and skill laboratories, ensuring process and standards for clinical updates for all midwifery educators have to be done. We need to introduce and enhance interprofessional education, or that is called the IPE, by encouraging midwifery educators to study and collaborate with the other professions. We need to introduce information technology based education and adopt the methods of information technology for teaching into the field of midwifery. Next, please. The indicators, as we said, that there has been a system for monitoring educators, which has been given by the WHO, which is a standardized assessment tool. So we can use this tool to evaluate the midwifery educators. Midwifery educators themselves should be engaged in research, publish at least one academic or research paper every year. And countries have a system to ensure and update knowledge of clinical skills in midwifery educators, which will be available and which could be used by them. Priority area 6, we need to develop and strengthen continuing professional development, that is CPD. Next, please. The actions which are required, that is, we need to establish and strengthen, we need to have a national mechanism for these particular continuous program or the development of the professional standards into the practice. We need to review and promote in-service training for midwifery workforce in collaboration with the government, which is taking place. We need to involve professional association stakeholders with a clear plan for career progression and for professional growth. Uh, there has to be encouragement of the peer-reviewed evaluation, mentoring at the workplace to enhance the skill, equip the midwife or midwifery educators with IT skills to regulate and take up the continuous professional development. There has to be innovation, which has to be brought about in the teaching programs, which include short-term courses by professional association and institution, promote self-direction, e-learning by practicing midwives to enhance skills and practice. Next, please. The indicators have been listed for monitoring. There are many countries who have the CPD mechanism for licensure, registration, renewal at all levels. So unless and until a midwife or the workforce, the task force or the midwifery educator, she upgrades her skills, her license or registration is not renewed. So we need to have indicators to monitor this. There has to be self-directed learning, skill upgradation and documentation. A midwife needs to upgrade herself, whether it is the task force or the working force or the teaching midwife. She needs to enhance and upgrade her skills in accordance with professional association who are there to support and to provide these in-service training and education. Next, please. There are certain other priority areas in the workforce planning and management, that is to ensure that each country has a national policy plan for midwifery workforce, which clearly defines the needs, place of work, socio-cultural aspects of the particular country. We have to ensure continuous monitoring of midwifery workforces and the standard indicators, and invest in increasing the number of resource and capacities of the midwifery workforce. Here it has been said that there are social cultural aspects which are relevant to each country. Therefore, every country needs to develop their own kind of protocols, keeping in mind the national priority or the national policy and planning for training of this particular workforce. Next, please. The priority areas for practice and service delivery, we need to ensure the continuum of midwifery care through the life cycle of a woman, that is right from the reproductive age, adolescent age, which involves families at different levels of the healthcare facilities as well as the community. Ensure an enabling environment for midwifery care providers. We need to promote a right-based approach to ensure respectful care for women and the newborns, and to ensure quality of midwifery care with continuous strengthening of knowledge, skill, and attitude of the midwifery workforce. Next, please. The priorities in research and evidence, which is the last strategic decision which is involved for bringing up the challenges. First is to identify the existing evidence and gaps, set priorities and conduct research based on the priorities. So unless and until we have evidence, we prove it, then we put it into practice, and that can be documented, which later on becomes a policy procedure for our practice in midwifery. We need to monitor and evaluate the progress, identify the challenge, and continuously update policy making and practice. So we need to remember that policies are reformed, policies are changed, they are renewed. This renewal will come only on the basis of the evidence-based practice, which we show during our care settings or in the care settings where we practice. Translating these evidences into midwifery policies, education, and practice. So even if we do researches, even if we come up with evidence-based practices, it should not be restricted to probably certain articles or publishing or putting it into your theses, but it has to come into the textbooks so that it reaches to the student, and evidence-based midwifery practice is what will help us to bring about or to face the challenges further. Next, please. So to conclude, we need to cultivate a good governance, which is backed by exemplary leadership. Therefore, we need to have leadership at all levels of nursing by utilizing the leadership capacities of senior nursing executives, as well as the bedside nurses. The patients, that is the woman, or the public, they have the right to receive the best treatment from healthcare providers, and this can be achieved with well-prepared workforce. So therefore, the requirement of midwives and facing the challenges can make nurses empowered, encouraged, challenged, and affirmed to continue and to excel, and they can do their best without any kind of barriers. Next, please. Therefore, the midwifery profession it has faced and worked through many barriers over the past centuries, resulting in significant progress in providing access to care to the woman and the families. However, midwives must continue to collectively and collaboratively work for change in the healthcare delivery system, especially in the culture surrounding the birth. To conclude, I would just like to give an example where probably all midwifery teachers do give this example in their classes. That is, overcoming barriers is like birthing a baby. The gestation may be long, but the birth is rewarding. Or if you can put it the other way, the labor may be difficult, prolonged, and painful, but the end result is worth the work. Therefore, changes in midwifery, however, depend on a strong workforce. So let us all be a dedicated workforce. Let us take the barriers, create challenges out of those barriers, and watch the opportunities bloom. So I would again like to thank the organizers, SOMI, MGM College of Nursing, and for giving me this opportunity. And I hope I have been able to contribute something into knowing the strategies to overcome the practical challenges.
Thank you, Supriya ma'am. Now I request the panelists or participants, if there is any doubts are there, please clear your queries. Okay, thank you, ma'am, for giving in detail the strategic directions. What are the actions to be taken? What are the priority area need to be regulated? And what are the action has to be taken? So I think there is no questions. So without delay, thank you, Supriya ma'am, for giving such a good informative session. Now we'll move on. Thank you, ma'am. Now we'll move on to the next session. Our next speaker is Dr. Rita Lakhani. Ma'am completed her MSc from LT College of Nursing and PhD from Krishna University, Karat. She's a gold medalist in MSc Nursing. Total 23 years of teaching experience and also extensive portfolio in pedagogic and clinical research activity. Received the first prizes in Avishkar Convention in 2010 as well as in 2015. In 2016, she was chosen as a guide for 2 students from the University of Montreal to pursue their internship studies comprising research work in India. She has published several papers and articles till date. She's a vice president in Oncology Nurses Association of India and associate editor for its official journal. She's also on the editorial board of CPQ Cancer Journal, and at presently she's a principal in D.Y. Patil School of Nursing, Nerul, Navi Mumbai. Ma'am, over to you.
Thank you for that lovely introduction. Can I request you to permit me to share my own slide?
Yes, ma'am.
Share my own PPT?
Yes, ma'am. Okay.
Preeti, is it possible that I can share my PPT myself?
Ma'am, you can share now.
Preeti, once again, thank you for that lovely introduction. And I'm happy to be a part of this conference. The 4th state level conference of SOMI, and which is co-hosted by MGM New Bombay College of Nursing. So I thank the entire team, the organizing team at MGM, for selecting me for this lovely topic that I have to speak on. That's rebirth of the theme of the conference is Rebirth of Midwifery in India, Challenges Faced by Midwives. And thank you for selecting me for sharing my thoughts on this beautiful topic, that's the changing nature of midwifery care in the state. To start off, I would say thanks to certain members because they helped me to build this content, since this content is not easily available to me. I thank Pravina at the first place. I thank Dr. Neelam Bansode. I also thank Dr. Manormani ma'am for helping me develop this content. And there are 4 other members who wish to keep themselves anonymous. So I thank the entire team who helped me to build this content. Fine. We always say that the journey of womb to world shapes our life. And I'm sure each one of you all will agree with me, because it all depends upon how the antenatal period was, whether we were maintaining in the amniotic, whether we were marinating actually in the amniotic fluid, or we were sparkling with our mother's emotions. As we leave the womb of a mother and we are coming to the world, it also depends upon how we have been taken care of by the obstetricians and the midwives. I would say obstetricians or the midwives, or obstetricians and the midwives. And after being born, whether we are close to our mother's breast or whether we are just put away in the cradle. Currently, when you look at it, you find fractured maternity care being operated. Fractured maternity care being operated under the medical system. And I'm sure when it is fractured, you will have a child who's actually going to come into the world is absolutely bewildered, not knowing what is to be done and how the child is being handled. Midwives, all of you all will also agree with me that midwives can help prevent 2/3 of all maternal deaths and half of the newborn deaths, provided they are well educated, well equipped, well supported, and authorized. And we need to demonstrate interest if we need to be educated, equipped, and supported and authorized. Working as a midwife, we will need to have an in-depth understanding of fetal and child development. It is also important for us to update and test our knowledge against all the experiences that we get as midwives. Now, this is a brief model that I've brought in about midwife. So in this model, it has been said that the midwife always attends to the woman and is present when she's laboring, when she's undergoing the labor process. It is said that the midwife complements and supplements the reflectiveness and the reflexiveness of the mother's instincts so that she can respond and reciprocate appropriately. The reciprocation depends as a labor process. So she'll have to reciprocate in different ways. I would want to ask a question to my audience. Have we lost in this reciprocity circles, or are we adequately reciprocating? Maybe some of the questions that I'll be questions that I've put over here would be even enlightened in the research that I'll be presenting now. So in her paper, do the pre-service education programs for midwives in India prepare confident registered midwives? The results showed overall 25 to 40% of the students scored above the 75th percentile and 38 to 50% below the 50th percentile of confidence in all subscales of antepartum, intrapartum, postpartum, and newborn care. The majority had not attended the required number of births prescribed by the Indian Nursing Council. Thus, they concluded that the pre-service education offered in the diploma and bachelor's program does not prepare confident skilled birth attendants as measured on the selected midwifery competencies of ICM. One of the underlying reasons was less clinical experience during the education, the duration, the content, and the pedagogy of midwifery education within the integrated program thus certainly needs to be reviewed. This is just a short study that I had done in my previous college in an organization where I had students coming from various colleges from Mumbai. And when students were interviewed, these are the major themes that came out. The first theme was with respect to time. The question was, your 4th year is completely cramped. 8 hours a day, you just get Sunday's holiday. So it's tiring. There's no time to socialize. And earlier, midwifery was a 6-month complete component in the GNM program. Today, it has been incorporated In the BSc also, you have midwifery, you have management, and you have community health nursing to be done over 6 months time, and then you have 6 months of internship. Is that possible? Is that possible in an environment when we stand out in the world? There are so many distractions. The media is more enriching, the media is more touching, the media is more invigorating. So is it possible to do all these things in a year's time? The next is the teaching. The teaching is very, very conventional. Students have said it's not at all challenging. It's so difficult to sit on the chair of the student and just keep on listening to the teacher, and the teacher is not even giving any clinical data. Teachers do not know much. In fact, there are students who have told me that in case if the mother is laboring, and when you have your second stage of labor going on, the crowning has occurred, there is flexion of the head. Which teacher has told me that you need to hold the head in flexion so that the baby doesn't come out fast with extension and cause injuries to the mother's perineal region? There are so many other instances that they have told me. So if the teachers do not know themselves, why are they asking, why are they expecting from us? The assignments, they feel the assignments have got no meaning because they feel that you have one student standing in front of 3 or 4 antenatal mothers. Are the mothers interested in giving us the data? Do we have a teacher standing beside us? The teacher doesn't even know 4 students writing the same assignments but getting different evaluations. So the evaluations are biased. We have very few evidence-based practice teachings going on, concept maps going on. The teachers only use these terms, but they don't really teach us using these concepts. Coming to fine skills, they say, okay, high fidelity mannequins are a faraway dream, but at least the teachers can teach us with standardized patients, simulated standardized patients, but even that's not expected. There's no desire that's being shown by the teachers. During the clinicals, as I've told you, 3 to 4 student nurses for one patient. Patients refuse assessment. No teachers around to support. When it comes to nursing care plans, they are never conceptualized by teacher community adequately. So we are also lost, and it's a very boring thing to do. Clinical nurses ask us to do the menial work because they have gone through the same kind of a phenomena when they were students. So there are concerns of becoming a nurse midwife. There are concerns of clinical competency with respect to midwifery. They wish monitoring and modeling through clinical education. So our findings reinforce the important function of clinical bedside tutors as role models. Let's move on to the rural area. In their paper, Malvankar Dilip and others, the changing role of auxiliary nurse midwife in India, implications for maternal and child health. In their working paper, they have said, the A&M is a key field level functionary who interacts directly with the community and has been the central focus for all the reproductive child health programs. In contrast with resident A&M of 60s who were providing delivery and basic curative structures to the community, today's A&M as a commuting multipurpose worker is more involved in all national programs and family planning and MCH services. Is that great? This has implications, therefore, on the implementation and outcomes of maternal health programs in rural India. This has been further reiterated by Malvankar Kranti Vora and Prakashama in their paper. Achieving Millennium Development Goal 5 is India serious when they said the midwives are missing. By reorganizing tasks and responsibilities within the health workforce, policymakers hope to make better use of existing human resources, that is the A&Ms, and expand and strengthen coverage of key health interventions, but it has very poor ramifications on MCH care. Further in their paper, Strengthening Midwifery Services in India based on lessons learned from Sweden and Sri Lanka, they have suggested adopting evidence-based interventions such as developing a skilled cadre of locally available midwives backed up by efficient referral and emergency obstetric care services will help India achieve the goal of reducing maternal mortality with the existing resources. Analysis also shows that establishing quality training, independent regulating body, and standardizing midwifery practices in India requires sustained efforts from government, professionals, society, and reorganization of health systems. Let's look at the interest that's been demonstrated by the administrators. In their paper, Achieving Millennium Development Goal 5 is India Series by Prakashama and Dilip, they concluded that India's MMR is high in spite of rapid economic growth, as they believe that the key reasons were political, administrative, and managerial rather than a lack of technical knowledge. So in the clinical scenario, absence of focus on emergency obstetric care, or if I would not use the word absence, I would say unequal distribution of emergency obstetric care all over the country. Lack of management capacity in the health system, no clear nursing leadership being demonstrated, no political will, varying concept of comprehensive maternal care services. I have my nurses today who tell me that when the mother is there for labor, every time, every half-hourly catheterization is being done so that the bladder is not full. And this is what they feel is a standard of care. So isn't this going to percolate down in teacher-student interactions, and what are the students really learning? But I do accept that there is a transition from yonder years to what is today. Let's look at the educational programs. The courses as A&Ms, the status has been upgraded. National Practitioner and Midwifery has come in. But when you have integrated courses like GNM and Basic BSc Nursing, it really needs to be evaluated for its efficacy. Curriculum revision. We all of us know it's quite time and high time that we need to revise the curriculum. Concept of midwife. I wouldn't want to deliberate on this in detail because over the last 2 or 3 months, we have deliberated on an NMC and have realized we don't have a clear definition of a midwife. Practice in clinical area, as I've said, it's fractured. In different hospitals, different things are being practiced, and the nurses over there, student nurses especially, feel that is the standard of care. So it's very difficult for our students to come back and bring them back to theory and tell them that these practices that are there in the clinical area are there, okay, but this is what is a reality. You all should be learning this. Confidence. Do we really think our nurses, our student nurses, have the confidence as they are undergoing various programs? I wouldn't want to touch upon those programs that have been undertaken by GOI. I wouldn't want to take up those 6 months program or 1.5 year program that the government of India has taken to upgrade nursing. Do we think that we have that much competence that we'll be able to take care of a delivery when we know today nurses yourself, please. Yeah, so when it comes to competency, do we have the competencies? Because we have not even conducted one single delivery ourselves. I remember the nurses who shared the period along with me when I was a student at KEM Hospital, we were just left in the labor ward. When I say left in the labor ward, that does not mean we were not trained, but we have conducted so many deliveries that if somebody wakes up in our sleep also and tells us, tell us the labor process and we'll be able to tell anyone. We were there for consolidated 6 months only in midwifery and not taken out and not moved anywhere. So the skills and the amount of competencies that we develop versus the competencies that the student nurses are developing today. If that's so, then the license that our students get when they're graduating out, RN and RM, isn't that a questionable? The GOI initiatives have come in. Lakshya has come in, giving us the great quality improvement project. NHM guidelines have come in. National guidelines for nursing and midwifery quality care in 2018 has come in. So wonderful initiatives have come in. Why? Because the government has now realized really the midwives are missing. And when things were in the midwife's hand, things were a lot better. So now when they have erased that memory from our mind, now they're working back again and trying to strengthen the nursing force, the midwife force. So I'm happy these kind of concepts are coming in, the newer concepts about water birth, about various ways of conducting deliveries, that's Lamas and so forth. Home birthing are coming in. Centers have been Various positions are being used. It's very difficult for me to make my students understand that if you have a woman who's in a sitting position and conducting her delivery, she's going to be more comfortable than a person who's lying down. It's so difficult to push the baby out. And all that you do is stand near the woman and say, "Aap zor nahi laga rahe ho, aap apne bachche ko nikal nahi rahe ho, kitni der se main khadi hu." My God, so difficult. So various kind of therapies have come in, and today respectful care thoughts are coming in. This is a thought of a midwife who has underwent, she's there right now, she's undergoing a training program at Fernandez Hospital. This is what is her thought. She asked me not to quote her name. Our education aims to facilitate this passion underpinned with feminist theory, enabling critical thinking, the use of evidence, and the ability to learn how to apply to midwifery school with heart and soul. Then at some point, the underground practice begins. When we set foot into the hospital, she asked me, "Why do you send us to the hospital? The hospital is only for the sick person. Why do normal births, absolutely that's physiological, have to occur in a hospital, which is a scenario of birth, which is a scenario of disease and death?" Here we fall into the deep chasm between theory and practice and experience the raw and visceral realities of the midwifery culture, which exist at
Hello,
present.
ma'am. Ma'am, excuse me, ma'am. Your slide is not sharing, I think so.
All this time it did not share.
Only in the interest that slide is there. After that, it is not moving.
You should have told me, no? Can you see it now? Can you see it now?
Ma'am, no, ma'am.
Not still?
No.
No, then...
Excuse me, ma'am. Kindly stop the sharing and then
yeah, okay.
start
I'll
the
stop.
sharing.
I'll stop the sharing because I've reshared it. I've resumed sharing, but I do not know. Okay, so I'll stop the sharing.
Ma'am, it's visible now.
Visible? Okay.
Okay.
Okay, I'll go back. Is it visible now? Is it visible now?
Yes, ma'am. Yes, ma'am.
Okay. So, this is the thought of a midwife who was sharing her thoughts after she's in the final days of midwifery training. She said our education and the ability to learn how to apply midwifery school with heart and soul. Then at some point, the underground practice begins. We set foot into the hospital. So here she asked, and she's told me, why do midwives have to practice in the hospital? Why do deliveries have to occur in the hospital? Because hospital is meant only for sick. Is a mother sick? She isn't. So why to go to the hospital? Here we fall into the deep chasm between theory and practice and experience the raw and visceral realities of the midwifery culture which exist at present. Where we thought we would be supporting women and spectacular physiology of birth, we find the technocratic perspectives in full force at every turn and every space. Be it antenatal birth suit or postnatal review, women being actively disempowered, intervened, and unsupported every day. Why do you teach us this then? So it's so difficult, even if we have taught those mothers to change the scenario. So this triple gap of competency, the value, the skills amongst the others who haven't gone the true maternity training, the coverage that is given in the clinical area to the woman, laboring woman, and access to a midwife, because a midwife is not to be placed in the hospital. This must be removed. I know these three are the major three things that I have specified. To put it into one slide and say to remove it is very, very easy. But to change competencies and values, such a difficult work. So we teachers have to work huge, massive work. When it comes to about coverage, again a massive work. When it comes to accessing the midwife, again a massive work. So the whole system has to be overhauled, and changing the whole system is going to take huge amount of time, huge amount of commitment, so that every childbearing woman has an access to a midwife's care for herself and her newborn, unless it is complicated. The International Confederation of Midwives envisions a world where every childbearing woman has access to a midwife's care for herself and for her newborn. So we need to demonstrate interest. So let's start off in small, small ways, as we can start off at our own level. Let's strengthen midwifery education, continue education programs, and the enhancing role of midwife as an educator. Let's promote midwifery research that enhances and documents evidence-based midwifery practice. Let's advocate for midwives and extend the influence of midwives in policy development that drives service direction. Let's pursue strategic collaborations with relevant organizations and network that shows a common interest as SOMI. So reinforcement of midwifery service clearly demonstrates the continuous significance of the roles played by midwives in the area of MCH care and the need to accelerate progress towards MDG 4 and 5, going on to SDG, what it is today. So we have awoken to the fact that midwives are required, and let's appreciate a skilled attendant providing skilled care will help achieve the goals of reducing both maternal and child mortality, and he will further grow with experience when his assignment is restricted to that specialty. So there is going to be a rebirth, a re-emergence of a midwife, because midwife care professionals as individual practitioners, leaders, and informers have a very important role to be played, and we need to make this an absolute reality. We all of us know this quote, I need not, but I just can't miss sharing it once again. The midwife considers the miracle of childbirth as normal and leaves it alone unless there's trouble. The obstetrician normally sees childbirth as a trouble. If he leaves it alone, it's a miracle. So let's go back to midwives who consider childbirth as a miracle. And I personally feel we must act to keep the knowledge and the powers of women alive. Thank you so much. If there are any questions that I can answer, I'll be just too happy to answer.
Thank you, ma'am. There is a query which is there in Q&A section. That is, how could we still confident in managing the midwifery cases? It is given by the retired Brigadier Mala Singh, ma'am.
Oh, lovely. Ma'am Mala Singh, very good afternoon to you. She's my inspirer too. Madam Mala, I think I'll be too meek in answering this question in today's context, in today's scenario. But I still feel if we all start working at a small level, like I send my students to maternity nursing homes. When they go to maternity nursing homes, you just have few nurses working over there. You don't have many doctors. And there are many maternity nursing homes, I mean, the municipal and the government maternity homes all around in each area. So I send my students in morning, evening, and night duty, and they get plenty of deliveries to attend. We have a lovely sim lab. I don't allow my students to go to the clinical area without attending simulation. If the simulation lab was not there, which I didn't have it in my previous college, I would do a lot of simulated patient cases. So we would become their patients and we would tell them this is how to do. I know I will not be able to do labor simulation, but most of the other things I would do. And that's how I would try and develop more confidence and more competencies into the students, depending upon the curriculum framework that's given to me by Indian Nursing Council. I really wouldn't know whether I've been able to answer this question, Madam Mala.
Thank you, Dr. Rita. You spoke very well, and that realistic challenges points you had brought. Actually, could I suggest in the same line as you were practicing?
Yes, ma'am.
So in that only I wanted to suggest, like we should, what happens when the student in the institution and the same place is used for completing the cases. So naturally you run short of cases, because the
Right.
same case is not only by nursing students, they have a medical students also in the colleges, so they
Perfect.
also use the same case, and that way that's problem comes. So what my suggestion was there, that as you said, you sent to some places where only midwife cases are there, so that is one thing. Another suggestion was there, like whatever at present whatever curriculum is running, because curriculum change also takes a longer time, in that one can improve upon by after passing out, means like detailing the students to the field of midwife in 1 to 2 group, like that way. Or see, in army what we do, we after passing out, whichever hospital, they are distributed all over India in various hospitals, field hospitals are all there, army hospitals, many hospitals type of, they are with less beds, they are with more, but family cases are always there. So whoever newly commissioned person joins whichever hospital, she is kept for 18 months
Okay.
in the family ward. Family ward consists of labor room, plus there will be an ICU, and then plus will be mother care unit will be there and all. So in rotation, those people are kept, and there is one senior one who takes care that they develop the confidence. Until unless she develops the confidence, she is not taken out, because what happens then, there are places where one or two nursing officer is managing the whole hospital, so she has to be very confident. That is our practical problem. That is why we started. We also face the same problem after this new syllabus, means now it has become old, I mean to say. After that 6 months which was being practiced by after general nursing midwifery course, after that when it was being practiced as a consolidated course of midwife and nursing, this problem came everywhere, but we managed like that way.
Okay, lovely,
Even
lovely.
I don't know how you all can manage. Either they, when they pass out, they should basis, and that
I'm
way,
sure we all are very, we all have our own instincts to see what are the resources that are available around us and to tap it to the best. I think that's the important message
yes,
that you have tried to give, Madam Mala. So you
yes,
have very clearly told us, okay, you have these resources, I had these resources, I'm sharing this with you all. It's only when we pull thoughts together we'll be able to look around whether we have more resources and tap them. Thank you so much.
thank you very much.
Do I have any more questions?
No, ma'am. The question only one madam is asked, and thank you, Mala ma'am, for that lovely explanations as well as sharing your thoughts. Any other questions?
Hello, good afternoon, everyone.
Good afternoon, sir.
Yes.
Madam, I just want to have a thing. I just want to add a thing that if a tutor in the field of midwifery, when they are being appointed or when they have been recruited for teaching the students in the midwifery section, they should be evaluated first. They should be evaluated, because nowadays, if we see, when we take a tutors in the midwifery subject like OB-GYN, when we recruit a tutor in the OB-GYN section, they are not been evaluated whether they are skilled with these all things or not. They should be skilled. They should be have a structured, means they should actually go with the OSCE if they are going with the skills in the midwifery or in the labor, what the antenatal, what are any of the sections. They should be evaluated first. Then they should be given students to teach.
Perfect. I think I will echo your thoughts, perfectly echo your thoughts. But it so happens that we have got certain guidelines that, okay, an obstetric teacher should have these qualifications and she comes in. And maybe even when we try to find out what is her knowledge, we fail because an interview or an examination can max go up to 1 hour's time. So, but I do echo your thoughts 100%. I wish, therefore, as I've pointed out in my presentation, most of the students have felt, I have my teacher, she's taught me this, she's not there in the clinical area. What she's taught me is not even there in the books. The books are giving us more clear idea. So they are aggrieved with the teachers that are there. But therefore, I say that when we are teaching our students, graduating our students from the basic program and the GNM program, each one of us will have to think at a heart, are we bringing out the right kind of students? Have we given them the right kind of a knowledge that they're supposed to receive? That they are supposed to receive as per the competencies and the objectives that are laid down by the Indian Nursing Council. That's very important. So I personally feel that I always tell my teachers, okay, you haven't learned something. That's fine. Now that you're a teacher, you have an opportunity. Before you go to the students, ensure that you're thorough. Ensure that you know so many things that your student feels blessed to be with you, blessed to have interacted with you. That's very important. So I 100% echo your thoughts.
No, because nowadays the thing has been we recruit the tutors, and the thing is they are not well versed. As I agree with your points that they are not well versed, and the thing they should be tested before, because like as you said, within an hour we can't just evaluate them, but we can keep them for a certain period of a time that you will be evaluated after these things. And they should not be go with the theoretical papers. They should be go with the practical papers. They should go with the clinical things. Like nowadays, if you see, when the medical students, when they come and observe in the labor ward, that like their labor ward practicals goes on, they do everything on the patient. They don't do it on the paper. In the same way, and now in the nursing exams, we all do it on the paper. We don't go with the clinical things.
Agree with you. I agree with you. We need to revamp all these things.
I won't be telling that the syllabus which has been designed is bad. It is good, but the working under this syllabus is something which is not good. Like if we recruit a tutor, there are some lecturers, there are assistant lecturers, there are professors, there are associate professors. They should evaluate these students, because these tutors are the thing. They are actually with the students. Like a professor and an associate professor, they won't be going with the students, but these tutors are always with the students. So they should actually be evaluated and they should be taught, because professor and associate professor level means the teachers, those who are sitting over there, they are well versed with everything. So they should actually evaluate the tutors first. Then they should send them to the clinical. Then only we can think our students, or our midwifery students, those who are taking knowledge in the clinicals, they will be thorough. They will be well versed with their clinical.
I echo your voice. I echo your thoughts. INC has already taken one positive step whereby they have said dual responsibility. Once this dual responsibility is going to be in place in most of the colleges, you will find right from professor, associate professors, assistant professors, all in the clinical area, including the principal. You will find there's going to be a dramatic change in the clinical area. And let's pray and cross our fingers that it happens very soon.
Definitely, because what we work over here is, though being I am a MSc in my OB-GYN, I used to visit the labor room over here with my tutors, so that I can evaluate my tutors as well as my students.
God bless you. Let's all wake up like that. Yeah.
Yeah, which gives me a part where I am lacking. I can learn it, because being a professor, that doesn't mean that I know everything.
Exactly.
Because in clinicals, what we see, we can't go with the books also. Clinical shows very different scenario when we deal with the patients. We can't go with the book as on the patient. It gives some different scenario when we deal with the patients. So
yeah, definitely, sir. Like we have to wake up as the teachers, as the professors, as associate professors, that clinical thing is more important than the theoretical part.
Everything, yeah.
Yeah. Okay, thank you, sir, for your giving your guidance as well as the expertise thoughts. And thank you, ma'am, for sharing regarding the changing nature of midwifery, especially in education and then in the practice. Thank you, Rita Lakani, ma'am.
Welcome, dear. Bye-bye.
We'll move on to the last session of ours today. That is the speaker of the last session is Dr. Manisha Kadam, who is having total 15 years of experience in the field of teaching and a member of academic bodies and board of studies in the institutional level, and also the PhD guide and the examiner to the various universities. Held the SOMI Maharashtra chapter treasurer post in the year 2016 and 2010, and presented various papers in the national and international level, organized and attended various conferences and workshops, and has published several papers in the national and international journals. Presently, she's working as a professor in Sadhu Vaswani College of Nursing, Pune. Over to you, Dr. Manisha.
Hello, am I audible?
Yes, you're audible.
Will you share my screen?
Yes. Okay.
Thank you, Preeti, for lovely introduction. First of all, greeting to you all from Sadhu Vaswani College of Nursing. It's a great opportunity, and I'll thank to all the organizing members and the SOMI members for giving me the opportunity to present and discuss on the government guidelines. It's a great opportunity to share the platform with all my mentors and all my respected teachers, Dr. Manonmani Venkat ma'am, Dr. Prabha Desila ma'am, Dr. Nilima Bhore ma'am, all of my teachers. So please forgive me if I'll do any mistake over there. Will you share my screen? Hello?
Is it audible? Is it visible, ma'am? I'm sharing.
No, ma'am. No, ma'am. It's not it. It's
not sharing. No, इधर नहीं आया. हमको नहीं दिख रहा.
Yes. Yes, ma'am, we can see it now. To be introduced about the government of India. Am I audible? Preeti, am I audible?
Yes.
Okay. Okay. So the topic was given to me is on a government of India's guidelines in improving maternity care. We all have been going through with these guidelines, and we get all the informations on net also, and all the way we are practicing in the clinical area. But still, as this is a last session, and I'll just brush up with all the guidelines at one platform. So first, I'll say something about the maternity care, what it means of the maternity care. So maternity care refers to the health services which are provided to women, babies, and the families throughout the whole pregnancy, during labor, and the birth after the birth, up to the 6 weeks, which includes monitoring the health and the well-being of the mother and the baby, giving the health education and assisting during the delivery and in the birth. Government of India adopted various guidelines towards the reproductive, maternal, newborn, child health, adolescence health, family welfare forms since 2005 onward under the one roof with the National Health Mission. Yes, please, the next slide. To start with the background, just I'll tell you about, as per the SRS. SRS is sample registration system, which gives the report annually every after 5 years regarding the maternity, all the death and the birth rates. So regarding the maternal mortality ratio, if you observe the maternal mortality ratio, I have not put all the ratio, but I say in a 2000, what was the ratio, and in the 2005, if you look after in the 2000, there was a 556 death rate was been seen with the maternal death per 1 lakh live birth, which was reduced up to 130 in a 2050. And presently, we have been considered as 113 per death rate, maternal death rate per 1000 live birth, it has been present. So there is a good reduction which has been observed in the maternal mortality rate all over the India. But if you look into the scenario with the district, the state wise, there are still few states are in a 3-digit figure, that is more than 300 maternal death per 1 lakh live birth, it has been present. So we are reduced from 11.3 points per year to 8% between 2014 to 16, but still we are not yet reached to the 5.8% rate, what it has been required as per the Millennium Developmental Goal. So the National Health Mission has kept the goal, we have to reduce the death rate below 100. So few of the states come up with the the reduction seen in the rate, but still we are not access with the things. So we are a long way in the terms of ensuring healthy lives and promote well-being for all of the ages. So India is committed to reduce the maternal mortality ratios to less than 70 per 1 lakh live birth and to reduce the neonatal mortality rate at low as 12 per 1,000 live birth by 2030 under the goal of sustainable developmental goal, which has been extended up to 2030. So positive birthing experience throughout the respectful maternity care is a new initiative in the Government of India's guideline. Next slide, please. So our target with the various indicator with the current situation and what we supposed to be go up to the 2030 to achieve that target. That is National Health Policy has kept this target to achieve the things. So there are various initiatives. Next slide. Various initiatives has been given by the Government of India. One is what we have been looking into the institutional deliveries, which is good change is seen in the number of deliveries are increased in the institutions rather than home deliveries or the during the transportation what deliveries have been used to be happen that has been changed. Now the most of the mother is getting delivered into the hospital, so that rate definitely it has been increased. Next slide, please. So there are various, as I said, various programs have been under the roof of National Health Mission have been taken place in the Government of India's guideline, like a Laksh. Laksh is what? That is the life-saving, this is a labor quality assurance, the labor room quality improvement initiatives, what it has been taken to improve the quality of the all the public health facilities. Points how it is to be improved. MCH wing at a one roof, capacity building of all the referral units, Dakshata, and the LASA, that is the life-saving anesthesia skills for emergency obstetric care. There is a strategy, what it is been given. Universal screening for HIV and syphilis for all the mother, comprehensive care, abortion care services, Janani Suraksha Yojana, Shishu Karyakram. These are the few of the strategies or the guideline, what it is given by the Government of India under the roof of NHM. Next slide, please. Next slide, please. So these are the some of the training manuals which have been available at the National Health Mission site also we can see. So these are the training manuals and the guideline strategies are being given under that which we can follow while taking care into the all the public health facilities. Next slide, please. So these are the manual and booklets in a PDF file also available. Okay. To coming with the Laksh, that is what we are say is a labor room quality improvement initiatives with the objectives to reduce the maternal and newborn mortality and morbidity rate. That was the main objectives behind of it. So to improve the quality of care during the delivery and immediate postpartum care, stabilization of complications and ensuring timely referral and enable an effective two-way follow-up system. So this is the main objectives. Third objective is to enhance the satisfaction of beneficiaries visiting to the health facilities and providing respectful maternity care to all the pregnant women attending the public health facilities. So these are the three major objectives have been kept under the Laksh to improve the quality of the public health facilities. Next slide, please. Next slide. So in a Laksh, the main components, what it has been said as labor room and a maternal the quality improvement initiatives. So the key components were organization and standardization of all labor rooms, birthing centers, all the operation theaters and the obstetrics, high dependency unit and the ICU as per the national guidelines and the standards. So these are the guidelines also are given by the Government of India under the Ministry of the Health and Family Welfare. So these guidelines has to be followed under the NHM programs by all the public health facilities, and they have to look after the organization structure into that, and they have to prepare their center in that way. So in auditing training quality indicators. This organization has to be monitored. Structure quality improvement. So they have given the standard protocols under the structure quality improvement effort processes to improve the adherence to the critical practices around the childbirth, and they are improve the client satisfaction. Respectful maternity care. So respectful maternity care is a separate individual topic where they have to give, they have to look as a mother as a human being, and they have to give a care to the mother in the labor room setting. So there are the they have been made few budget towards it, and they have given the different grading to the under that. So they have given the badges platinum, gold, and the silver. Once the labor room will get been audited under this under the Lakshya program, so they will get certified, and these certifications will be given in the badging like platinum, gold, silver, depending on their performance or their achievement target. So 75% they should be achieve the target when they will get the silver, gold, or the platinum. 80% satisfaction beneficiaries will be given them. They will get more incentives towards the facilities to be improve the organization, to improve the structure performer of their public health facilities. Next slide, please. So that is about the Lakshya. So in a Lakshya, there is a different the four major the components have been taken. That is, one is a standard of care. That is under that national quality assurance standard Dakshata, where the training will be given. Then the competent and the training services have been provided under the Dakshata training. So every they will get the training under the TOT's training manuals have been available, and training centers there they can go and get the training over there in those centers. Facility ownerships and the accountability. So quality indicators, that is care around the birth, approaches, learning from the USAID and assisted them. White Ribbon Alliances have been taking care of the optimum experience of the care to the areas and the care around the birth approach. So they have all these indicators, and the standard protocols have been given under the Lakshya, which they have to be followed to be harmonized the effect in the public health facilities. Next slide, please. So at presently, the under the Lakshya facilities, there are 2,235 centers which have been under the quality indicator have been registered, the certified, and out of that 179 medical colleges have been who have been the tertiary hospital case have been certified. So state certified labor room are 115, state certified operation theaters are 97, national certified is the labor rooms are 54, and national certified OTs are 38. So these are the certified by the Lakshya facilities indicate under the indicator, and they are got the good certifications with the Lakshya indicators. Next slide, please. So second, the thing what we are saying, obstetric high dependency unit and the ICU. So this is again under the Lakshya program also, and under the initiative is with the TOT. There is a need of a critical care unit is been added by the NHM programs, where the more than 1/3 of all the maternal deaths have been get recorded either by the medical college hospital or the district hospital. So by scene of these death auditing records, the national guidelines for obstetrical ICU and high dependency units were developed, and which is got released in 2016 to improve the high dependency unit, or to be been added in high dependency unit to the district level. So these operational guidelines complements the already which is existing in the terms, like they are increased with the human resources. They have given a more detail about the human resources, what is their strategies, what they have to be followed. They have been increased with the building area or the plan. They have been reframed the area of the labor room and the high dependency unit, what it is been required. They are equipped with the details, what it is been required, and the records and reports formats have been changed, and that also been increased into the guidelines. So these are the operational guidelines have been given under the obstetric high dependency unit and the ICU for the especially for the maternity care. Next slide, please, Preeti. So there are other guidelines which have been services been implemented with the things, that is a free and the zero expenses delivery included cesarean section. That is a free care in a case of antenatal, postnatal mother if there have been complications. So when the mother comes to the public health facilities, she is a free with the service in an emergency also, or she is a registered case. Free drugs, free diagnostic things, blood and the consumable, whatever it is been required, blood donations or blood administrations, those all the things are the free of a cost will be given to the mother. Free diet during the stay in the hospitals, in the facilities, from the time she's got admitted to the hospital, whether it is a normal parameter or whether it is a high risk conditions. Free transport from the home to the health institutions. From if they call up to the 102, they just get the free transport service to reach to the hospital. Health institution to revert back to her home after the discharge, or if she required to be referred for the further high dependency unit, then that transport facility also will be on a free of cost and drop back to the home. Exemptions from all kind of user charges, whatever the health services have been required her into the clinical area, those all the charges will be get free of cost. Extended to all the antenatal and the postnatal complications have been treated on a free of cost. So this is again very important. The change have been taken place in the package. What additional things have been added in 2011 with the NHM package under the RCH interventions. Next, please. There is a Pradhan Mantri Suraksha Matritva Abhiyan, which has been initiated, and the package what it has been given with the quality antenatal checkup services have been given all over the India, which has been conducted, and over 9 lakhs identified under that, and these services have been given with this Pradhan Mantri Surakshit Matitwa Abhiyan. Dear doctors from the private and the NGO sectors have been hello. NGO sectors have been yes from the NGO sectors and the hello. Over the 5,500 voluntarily doctors from the private institutions and the NGO sectors have been taken part into this Abhiyan, and they are providing the services toward the hello. Next slide, please. So, so next is a Daksha training that is again under the NHM program given towards all the skill training to all the health personnel who have been working under the public health facilities, where they are giving a training, and they have been also increase the skill labs. So the labs have been got added into the district level centers, and these national skill labs have been added to the district levels, where they are giving the training to all the trainers, to the all the skill personnel, skill attendants at birth who have been going to be present, to the doctor, midwives, auxiliary nurse midwives, and then what we can say female health worker, multi-purpose health worker, female, who are getting training under these things. So there are the lady, there are various hospitals who have been taking part into this enhancing the labs, skill labs, and they are taken participation into all this at the national level with the skill labs. Next slide, please. Dakshata is a strategy initiative to strengthening the quality of intra and immediate postpartum care. So again, in the skill and the improving the skills and the competencies, where they are providing the training to all the SBAs, what we call, that is a TOTs, batches wise, it has been given the training to all the throughout all the states, that is a Rajasthan, Andhra Pradesh, Jharkhand, Maharashtra, Odisha. These are the various states which they have been following, or they have been increasing with their trainers, and they are increasing the health facilities with the skilled personnel. Next slide, please. Next slide, please. So as we are saying under the Dakshata training, the trainings are being given to the skill birth attendants on the SBA skill birth at attendance. There is a manual which is been present with the TOT training is been given to all the midwife. Hello. There are the various trainings have been given under the one roof with the lab with the skill labs under the trained skill labs, that is a life-saving anesthesia skills for emergency obstetric care, emergency obstetric skills to the doctors, all the medical officers at the districts and at the primary health centers. All the midwives has to be undergo with this 21 days training with extensive clinical experience into the district level hospital. So these are the few of the manuals or the training manuals which they have to be undergo under the Government of India's guideline. Next slide, please. So saying something about the few of the respectful maternity care where they have been trying to provide access to the quality maternal and newborn health services, where they are promoting natural birthing for promoting positive childbirthing experience. So with these, there are the few centers what the Government of India is given the beneficiaries or they are under the trial and error basis where they have been trying to be improve the centers for the maternity, call it respectful maternity care, where they are modify their labor birthing places. We can say rather than saying as a labor room, birthing places have been modified with all evidence-based practices. Like as ma'am said, Hyderabad is the center where we have been saying as Choitram, where they have been the practicing like that in Maharashtra also under the Government of India's guidelines and under the we can say as under the guidelines, they have been midwifery led unit have been improved in the public health facilities and where they have been practicing with the respectful maternity care. So they are separate cadre of the midwife skills as per the competencies have been prescribed at the International Confederation of the Midwives. Those have been following as we are saying as a nurse midwifery practitioner. So that also is been certified and regulation as per the Indian Nursing Council. Midwifery lead unit care have been come up with a revision of a current 1 year NPM programs to the curriculum to 18 months. That is also entered. To be given about the Lancet service on a midwifery 2014, safe and effective midwifery care can be awarded 83% to all the of all maternal death. So this taking into considerations, so there are the few guidelines have been reframed into the Government of India's under the NHM. Next slide, please. There are other beneficiaries or the other strategies also have been added into the Government of India's guideline, that is Anemia Mukta Bharat. That is to be not only for the maternity but all the under 14 years age, there these services have been provided school to school from we can say it is from one village to village primary health centers what they have been providing the iron supplementations to all the schools where they have been providing folic acids and the iron supplementations to all the public under the public health programs to try to be prevent the anemia or to reduce the anemia percentage into the female. So that is again periodic deworming of the children's, adolescents, pregnant mother, testing of anemia using digital methods and point of a care treatment, addressing non-nutritional causes of anemia. So these are the few of the things at the PSC level. The Anemia Mukta Bharat strategies are being utilized with the primary health center. Next slide, please. This is a nutritional promotion program, which is also a Poshan Abhiyan, which has been taken by the Government of India to enrich the food with a micronutrient by fortification to address the micronutrient deficiency. So new fortification standards for rice, wheat, oil, milk under the Ministry of the Health and Family Welfare has been released. Facility-based management of sick children and a nutritional rehabilitation center have been added. With adolescents program has been added with the supplementation of iron, Poshan Abhiyan has been added with the under 5 children and adolescents and the pregnant and the lactating mother. So these are the few under the few strategies have been given under the Poshan Abhiyan by the Ministry of the Health and Family Welfare. Next slide, please. As we have said about the Laksh, the program, there are also portals have been opened where the software, the portals have been directly connected with the central. That is a Laksh portal where a digitalization of all the Laksh related data has to get entered in by the NM into the software. So all the states referral units requested to log in and upload all the Laksh related data into that portal. So the ministries, state, district, and the facility centers, all they will have their own 4 logins, and they have to get entered all this data. So it is a once portal will give you all the ideas or all the informations what it is happening related to the maternal health into the India. So the RCH portals and Anmol portal, which has been done for the children's, then the maternal wing management information system, that is MWMIS portal, which is giving about all the maternity information under one roof. Kilkari, that is a messages after the delivery will be given to the all the mother and child tracking and the facilitation centers, that tracking services. So these all the portal will get the informations from the ANM. They will enter, and this information directly we can get login with the national ministry, with the state and the district facilities. Next slide, please. So we under this we also National Ambulance Service, which has been a free of cost with 102 toll-free services have been operationalized from the year 2011 to all the mother, where they can be free services have been given to from the pickup point till she will reach back to her home after the delivery or after any complications, or she will get a referral services with this ambulance. Next slide. As I said, there is a further referral unit and ICU has to be reframed. So the separate operationalize threefold increased with all the centers. So all the centers have been referral united are reorganized, and further budget has been approved toward it to extend or extensively they should be further reframe their further referral unit to take care of the mother at the state level and at the district level. Next slide, please. So one more very important thing which has been taken place into the Government of India's guideline, that is primary health centers. If you observe the primary health centers, initially what we used to say as primary health centers used to be with the 6-bedded hospital, and they were used to give the care to the mother during the daytime. But the PSC centers are further improved with their organization and the structure, and they made to be provide the services 24/7. So 24/7 the services are been available with the centers at the primary health level, and they are further referral unit is been given to them where they can be referred if in an emergency the services are available. These primary health centers are been extended with their facilities, with their services, and with the competency level skill personnel is made available at these centers. So that is a reframe change what it has been observed by the government of has been done by the government of India to all the primary health centers. So all the delivery will be takes place at the institution. Next slide, please. Again, the renovation has been done with the labor room and the birthing centers, and with the antenatal care, waiting area, postnatal waiting area, where the mother is now remain for 48 hours after the delivery. So renovation and upgradation of all the centers, so with the availability of the facilities have been made into the centers. Next slide, please. So main area of the concern is the indicator, that is mother who had at least they are the main indicators under the group of this is she should visit at least 4 times to the antenatal during the antenatal period, and institutional birth should be takes place those all the mother and all the pregnant mother in the age of 15 to 49 should not be have anemia or their HB should be more than 11 grams. So all those should be able to be identified. What we have been observed with the date major causes. Those should be at least we can able to be prevent those causes. Next slide, please. So few of the evidence-based practices also is been followed in as under the government of India's guidelines. That is a delay cord clamping is now started practicing at all the health centers. That is delay cord clamping show improvement in the oxygen saturation of the newborns. ANC guidelines, revision of the ANC guideline, which is under the terms and ANC visit, various services provided during the ANC visit, those also have been followed, and tracking system is been improved into the things. There is also focus on a respectful maternity care. So in a TOT training, they have been tried to be improve the try to be change the attitude of all the stillbirth attendants towards the maternity care, and try to be focused on the respectful maternity care, and evidence-based practices can be independently been practiced into the maternity center. Next slide, please. So these are the few of the changes what it has been done, and these are the retraining strategies has been given by the government of India under these quality indicator systems. There are other things also they have been specified, like there are, as we have said, training, especially with the life-saving anesthesia skills training for emergency obstetric care. So they have been specified with the weeks of training should be given, and that made is a compulsory to all the doctors who have been working and practicing into the primary health centers or the sub-districts and the district level. All the ANMs, staff nurses, LHVs, they should be trained under these 3 weeks, and they should be considered as a skill birth attendants, and they are the skill labs. That is what we are saying, Daksha training, what is for improving the skills of a healthcare provider and to enhance their capacity for providing quality reproductive, maternal and child healthcare services under the government of India, which is the national skill labs has to be improved. So these are the few the government of India's guideline towards the maternity care. I'm not been going in the detail of all those the programs or the modules what it has been said, but this is a brief about the guidelines what it is given by the government of India towards the maternity care till today, we can say. Thank you.
Thank you, Manisha Kadam. Any questions? Okay, Manisha ma'am has given in detail regarding the different government of India guidelines, which is given by the government of India regarding the midwifery. So we are ending the session for today. That is of first day of virtual e-conference. I had given the feedback link in the chat box. Kindly fill that feedback link, and so that your presence will be evaluated based on that. And tomorrow's link will be provided in your mail. And tomorrow we'll start exactly at 10 o'clock so that we won't be delaying in our sessions. Kindly fill that feedback form. And tomorrow at 10 o'clock we'll be meeting. We'll send you the mail link through your mails. Thank you.
Thank you, Preeti, for giving the opportunity to present my things. Hello.
Thank you, Manisha.
Thank you, thank you.
क्या हुआ?
You can inform, Preeti, you can inform the closure of this conference today.
Yeah, I've already told them, ma'am. Today we are winding up today's session, and tomorrow the link will be provided in your mails for the tomorrow's session at 10 o'clock. And the feedback is already provided in your chat box. Kindly fill that feedback forms. Once you fill the feedback form, you can leave the session.
इस दिन अपन इस ग्रुप को रख रहे हैं, इस दिन अपन इस ग्रुप को रख रहे हैं। और मॉड्यूल हम आपको बना के भेजे मैडम कि आप बना के रख देंगे?
इसका मॉड्यूल ट्रेनिंग का मॉड्यूल
तो फिर आप वो मुझे दे दीजिए। जैसे ट्रेनिंग मॉड्यूल मैडम अपने को दे दीजिए। और तीसरी चीज, अब कोई हम IT वाला पकड़ते हैं जो हमको ये वाली कहानी सॉल्व करेगी, वो कैसे कराएगा। लेकिन फिजिकल में तो आप लोग को आना पड़ेगा ना। तो फिजिकल के लिए फिर ऑलरेडी हम और ये सब भी लिखिए, खाना पीना का अरेंजमेंट भी फिजिकल में रहेगा। और डॉक्टर अभिजीत